Good afternoon and welcome to the Royal Society of Medicine. Thank you so much for joining us today, and a particular welcome to all our members who are here with us this afternoon, and to all of you who have come to listen to this excellent event. It's the latest in our series on Medicine and Me. And today we are looking at unmasking lipedema, a women's health condition hidden in plain sight. And for those of us who are not so familiar with the Royal Society of Medicine, we are a membership organisation and a UK charity dedicated to healthcare education, advancing health and education of healthcare professionals generally, as well as the public. So through learning and collaboration, we enable these events to take place, and we support professionals and we support the public to generate and have a better understanding of healthcare and practice, and how to improve patient outcomes. And what's particularly great about these events in Medicine Me is that we are speaking and hearing from professionals and patients as well. So it's a really rich experience that we have here today for you. And it gives me great pleasure now to hand over to the chair of Lipedema UK, and that is Sherry Fetzer, and she is going to take it from here and tell you about what's in store for you this afternoon. Thank you so much.
Thank you so much, Professor Manning. It's such an honor to be able to present to such a great society and all your members. And I would just briefly like to thank everybody who's contributed to make this event happen today. Your team have been absolutely wonderful. And I would especially like to thank the anonymous benefactor who's funded this series, because as a charity like yourself, that's what we rely on: donations and help from all sorts of people to help us on this journey. Our team of medical experts, which you'll be hearing from today, are truly remarkable people who have donated a lot of their time, skills and passion to change the lives of thousands of patients. And I thank them here, all of them taking part today. Our patient contributors are wonderful people who are speaking up about something they've probably kept very quiet about for many, many years. And my Lipedema UK team, who support our members and our patients and help us do these sort of things as often as we possibly can, because unmasking lipedema, making the word a familiar word to a far wider reach of public and healthcare professionals, is our aim, because we know once we've cracked that, we will get the cures and the treatments people really desperately need. I would finally like to thank Mary Warrilow, who has led the whole project, and she has complete professional passion and served patients for many, many years, and very dedicated to her task. So Mary is an outstanding professional, and the time she gives to us is such a bonus to us. So I'm sure I've left somebody out. If I have, I apologize, but I know time's short. So I'd like to now welcome Suzanne Evans, who will be chairing the first session. Suzanne is another remarkable person because she was our original founder of Lipedema UK, and it was her "let's go and get this done" attitude to opening the door to lipedema and creating lipedema. So over to you, Suzanne, for the first session of our 3 sessions today. Thank you.
Thank you very much, Sherry, for that fantastic introduction. Yes, I'm Suzanne Evans. I founded Lipedema UK. I have lipedema myself, and it was something I lived with and that my family lived with for many, many years before we got a diagnosis. I was only diagnosed actually when I was 45. That was a shocking 15 years ago now. But it was something that was always in my family. My mother had it, my daughter has it, my grandmother had it. And so it's been fantastic getting Lipedema UK together and working with inspirational people like Sherry and some of the medical professionals that you'll be hearing from today to take this forward. So session 1 of today's program is understanding lipedema. It's all about understanding lipedema, the foundations of diagnosis and management. And what I'd like to do is to kick off with a video in which you'll hear from some patients about how this disease has affected them, living with lipedema, the challenges of getting a diagnosis, and impact on quality of life.
Hello, I'm Mary Warrilow, Director of Strategic Partnerships at Lipedema UK. In just a moment, we will hear from some incredible women who will share just a glimpse of their lived experience of living with lipedema. They'll talk about how they first recognised the condition through to getting a diagnosis or the difficulties with getting a diagnosis and managing the condition.
I've had lipedema since puberty, since I was around sort of 14, 12, 14 time, because I vividly remember having to buy a skirt to fit my legs rather than to fit my waist, and then it's grown from there. I found out about lipedema through a friend who sent me a link to Lipedema UK, and through Lipedema UK I was then able to get a diagnosis. But for me, I think, yeah, as I say, it's from pretty much from puberty, and then I just found my arms grew, and I remember because I fell pregnant at the age of 15 and had my son when I was 16. And I remember people saying you have big arms because you didn't breastfeed, and also I have been told that I've got big legs because of my culture, and also a big bum because of my culture. So it was it's sort of, I grew up always having my arms and my legs much bigger than the rest of me, and it was very disheartening at times, especially when I got into exercise and trying to lose weight. It would always come off the middle of it, but not off my arms or my legs. And I found out about lipedema probably at the right time. I was almost ready to just give up and not worry about what I ate or exercise and things like that. How it's affected me mentally, it has been quite brutal at times. I have felt very disheartened and wanting to give up, and you know, wondering why I was this odd shape, and you know, all the things I go trying to buy clothes was such a trauma for me, because I just hate it, and even to this day I hate clothes shopping. Physically, obviously, it was the pain. That was the main bit for me, because I did in my 30s start exercising, and I actually grew to love exercising. But my legs were always so heavy, my arms were so heavy, and it made exercising a little bit more difficult, but I persevered because I enjoyed it. And as I got older, probably from mid-40s to when I had my surgery, my limbs were really just got heavier and heavier. And I remember probably about 2 or 3 months before my surgery, I was doing a Zumbathon, because I teach Zumba and I'm a Zumba instructor, so I really love Zumba, and it was one of the things that helped with my mental health and well-being. And I remember doing a class and thinking, I don't think I can do this anymore. As much as I love Zumba, I don't think I can do it anymore, because it's just so hard. Everything was hard, the pain, and after it, you know, when you've done the exercise, lying down at night, you would feel that burning pain, the throbbing, and the constant, and also the pressure, the constant bruising, and everything that goes with lipedema.
Until about 5 years ago, I was living with a condition that I couldn't name, I couldn't explain, and I certainly couldn't talk about. All I knew was that I was different from most other women. I didn't know why, but it affected my self-awareness and my self-image for literally decades. So I'd spent my life becoming an expert in adaptation without even realizing it. For example, those long, stylish jackets that I favored and the long jumpers, they weren't really a fashion choice. They were, I guess, my armor to hide my silhouette. Because when you spend years unconsciously arranging your life around concealing parts of yourself, it becomes exhausting. And it wasn't until about 15 years ago, I went to spend the weekend with my mum, and I wore crop trousers one day, and she took one look at my legs and she suggested that I had lymphedema, the same condition that she was managing at that time. But I compared our legs, and I could see marked differences. And that moment ignited something in me. So I went home and I became, I guess, my own medical detective, diving into medical journals and patient forums and stuff like that for months. And it was through this research and actually through finding the Lipedema UK website as part of this research that I discovered I likely had lipedema. But I didn't do anything with that self-diagnosis for a while. It wasn't until about 4 or 5 years ago I plucked up the courage to go and see my GP. And I guess I was hoping for answers and maybe some validation. But instead, what I got was a very quick glance at my legs and an immediate misdiagnosis of lymphedema. And that consultation was so brief and so dismissive that it doesn't even appear in my medical records. And to this day, I have never been back to correct that particular GP. So yeah, living with an unrecognized condition means you become incredibly resourceful, but you also become profoundly isolated because there's no roadmap, there's no coordinated care. You literally end up searching for all of the stuff for yourself and finding out about all of the stuff for yourself. And that shouldn't be how healthcare works.
On reflection, I developed a very unhealthy relationship with food. I tried every single diet that there possibly was, and despite much willpower and commitment, my legs never reduced in size, which again really impacted my confidence in a very big way. So as well as my lifestyle, my career was also very much influenced by the size of my legs. My early career was involved a lot of standing. However, at the end of every day, the pain in my legs and generally in my body became too much to bear, and I just couldn't understand how my colleagues didn't have the same problem. So I was directed more towards roles where I could stand and sit, and that has continued all the way through my career. Lipedema has also affected my experience as a mother as well. From the early stages, if we go right back to going through the labour with my first daughter, there was a few complications and a lot of medical professionals had to come into the room to support the birth. All I could think of at the time was how embarrassed I was at my legs being on show. I felt sorry for the midwives and the doctors that had to touch my legs. And that, when I look back with a lot of sadness, took away that experience of being present at such a special time in our lives. And having another daughter as well, and my daughter's growing up, again, the pain and the heaviness of being able to be out and about, running around, being with them, certainly impeded my experiences with them. Again, I was always covering up, even on the beach, and there isn't a photograph of me with the girls without them either standing in front of my legs or sitting on my legs or me hiding behind something to cover up my body. I longed to be able to go into the sea or into the swimming pool with them, but just didn't have the courage for fear of comments or glares or looks. So I would always be sat on the side while my husband would be swimming with them.
When I was first diagnosed with lipedema, bruising was definitely something that I would have all the time. Any touches or bangs to the legs, I would get a bruise. So after all these surgeries that I had, my arms and legs were black and blue. But I think the manual lymphatic drainage obviously helped release the pressure in my arms and legs. I haven't had manual lymphatic drainage since my surgeries. I do wear compression garments from time to time. I can't say that I wear them every day. When I go on a plane or if I'm in a car for a long time, I do wear my stockings as this really helps with the swelling. Apart from that, I do have an active lifestyle. I'm on the Peloton bike, say 4 to 5 times a week. I keep active, I go on walks. My job is pretty active. I'm on my feet all day. I notice in the summer months when it is hot that my legs at the end of the day do feel rather heavy. So sometimes I do wear my compression garments at work. Every 6 months, I was having a consultation with the lymphedema nurses at St George's Hospital to measure me up for garments, which were on the NHS. I attended these consultations from after my first surgery back in 2018 to the beginning of 2025. In my most recent consultation, they took the measurements of my arms and legs and they've confirmed that they haven't changed size. So therefore, I am managing all my lipedema symptoms myself. And I'm actually really proud of this. They decided there and then to discharge me from their care. I have all the compression garments that I need, but they made it very clear to me that if I ever need any more support with my lipedema or if I'm struggling with lymphedema and I need any more garments or support, that I can get back in touch with them and they will be able to support me, which I'm so grateful for. My family and I are super fortunate to have been able to have all of our surgeries funded privately. My wish is that every woman in the UK who has lipedema at any stage to have the opportunity to have these surgeries too. By supporting Lipedema UK, with their research, we are hoping that the NHS will recognise lipedema as a medical condition and that all women will be able to have treatment that they deserve.
4 really powerful patient stories there, and I think for those of us with lipedema, they're absolutely typical. You know, that talk about finding difficulty buying clothes, finding difficulty exercising, the embarrassment and the shame we feel, the misdiagnosis of lipedema and obesity, all very, very common patient stories, but also really good to hear that message of hope there from Charlotte at the end. So that's some of the patient experiences, and I know we'll be hearing more of those throughout the day. But let's move now to the medical opinion. So I'd like to introduce Professor Christiana Gordon. Christiana is our patron and medical advisor at Lipedema UK. She's also a consultant and professor in dermatology and lymphovascular medicine and clinical lead of the lymphedema service at St George's University Hospital's NHS Foundation Trust in London. And she's going to be talking about what lipedema is, the symptoms, and the importance of an early diagnosis. Christiana.
Thank you very much for that introduction. Hopefully everyone can see my slides. I'll rely on someone to shout out if something goes wrong, if that's okay. Thank you very much for the opportunity to speak to you all this afternoon. It's an honour. And it was fantastic to see those patient videos as well beforehand. I hadn't seen those before and it was, yeah, they were just fabulous. So thank you to everyone that contributed to those. So I will try and keep to time and talk to you about lipedema, the symptoms and the importance of an early diagnosis. So the overview of my talk this afternoon will be, I'll try and explain to you what lipedema is, but as you'll realise, we're not completely sure yet. But we are fairly confident about the symptoms that ladies living with lymphedema will experience and the signs that we as healthcare professionals can detect. I will try and guide you through how lipedema can be diagnosed, but it's not always easy. I'll briefly touch upon the current management options, but colleagues later on will be diving deeper into these, and my thoughts as to why an early diagnosis matters. So what is lipedema? Well, I think it's easy to start off with saying it's a very poorly understood and until recently very poorly researched condition. It was recognised in the medical literature almost 100 years ago, but nothing's really moved forward in terms of furthering that understanding until the last 10 years or so. So to start off with, let's talk about what lipedema isn't. It is not obesity. It is not lymphedema, as we've heard from those patient videos. But both these conditions can occur in someone living with lipedema, which can make it very hard to make a diagnosis for the healthcare professional that has this lady sitting in front of them, struggling and asking for help. So lipedema, as I briefly mentioned, was described by Allen and Hines in the 1940s and published in the literature. And they described it as a painful fat disorder affecting women, and we still agree with that concept today. It pretty much is an exclusive condition to women. Very few men appear to suffer with this condition. And it presents with symmetrical, that's key, but disproportionate fat deposition of the limbs, typically the lower limbs, but I think many women over time find that their upper limbs are involved too, and rarely it can just affect the arms. What's key is that many women describe tissue tenderness. So if somebody touches their arm or knocks into them, it hurts. And they do comment on easy bruising fairly regularly, but not everyone suffers with tenderness or bruising. When does it come on? Well, we look back and we say, with hindsight, when do you think you notice changes? And the majority of women will say around about puberty was when I noticed that my legs were different from those of my friends, or when I noticed that they were heavy or painful. But it also seems to occur at times of hormonal change later in life, like going on the contraceptive pill, being pregnant, taking HRT. And many healthcare professionals that specialize in lipedema also believe that it can be triggered or become visible at times of weight gain. It's definitely exacerbated by weight gain. And obesity often complicates the clinical picture. And that makes it difficult for healthcare providers to make an accurate diagnosis sometimes. Frustratingly for everyone, there is no diagnostic test available for lipedema yet. It is a clinical diagnosis. It's likely underdiagnosed by healthcare professionals, and it's often mistaken for lymphedema and or obesity. And how common is lipedema? It's difficult to know because there haven't been that many studies on it, but there's an estimated prevalence of about 10% of women will have features of lipedema. And lipedema is a spectrum. The clinical signs might be subtle or they might be severe. The symptoms might be subtle or they might be severe. Many people ask us, what's the cause of lipedema? It's difficult to know. We really don't understand this condition yet, but the majority, in fact, almost everyone, I believe, working in the field of lipedema is confident that genetics play a part. The majority of women that are diagnosed with lipedema will be able to identify women in their family that also suffer with lipedema, whether it's diagnosed or not. We also strongly believe that hormonal influence plays a role. So puberty, pregnancy, menopause, timings of onset of lipedema strongly suggest that hormones play a link. There's emerging evidence that inflammation within the fatty tissue plays a role. And as I alluded to earlier in the talk, in recent years, lots of research has been taking place in lipedema, but these are very early studies. The numbers might be small. We're still trying to analyze whether these case reports, these small studies, the data, the hypotheses and conclusions drawn from them, are they accurate? We need to do more research to validate these findings. So at the moment, we still really don't understand the causes of lipedema. But I'd just like to take the opportunity to share with you some of the work being done at St George's Hospital, together with collaborations with other colleagues abroad, looking at the genetics of lipedema, because we feel strongly that there is a genetic susceptibility to this condition. And this all started maybe 20 years ago, looking at patients that I was caring for in the lymphedema clinic at St George's. And I remember this lovely lady, she has a diagnosis of lipedema. And she's really special to us because she has an identical twin sister. And that's, the ideal person to have help you with genetic studies. So these two twin sisters who are identical, they have 3 daughters and between them, and 2 on the right are showing signs of lipedema and the one on the left isn't. So we asked this lovely family if they would help us with some genetic research, and they agreed. And this study back in the early 2000s, we were identifying patients from our clinic at St George's, and all of them had been referred with suspected lymphedema, highlighting the frequent misdiagnosis of these women. And blood was taken and limited genetic research was done, bearing in mind at this time everything was just so much slower than it is now. It would take me a year to sequence one gene in the lab, whereas now you take a blood sample, send it off, and within 3 weeks you've got the whole genome sequenced. You then just have to work through all the data that you're getting back, but it's certainly much quicker and cheaper to do genetic research now. So just want to share with you the types of families that we were including in our studies, and these are family trees. Squares are men, circles are women. If you're shaded in, it means you're affected with lipedema, and you can see the family in the top left here are identical twin sisters and their 3 daughters here. And then we've got just some other families, several generations of women living with lipedema that kindly donated their blood to our research. And we published the paper in 2010 and were rather frustrated that we hadn't found the underlying genetic cause, but definitely the familial nature of lipedema suggested heritability, and our colleagues abroad were in agreement with us. So then we took some further steps looking for more answers, and perhaps we're looking for genes that increase the risk of developing lipedema, so a common genetic risk factor, or perhaps one gene that exclusively causes lipedema. So families from one generation to the next will inherit this gene mistake. And why are we bothering to keep researching? Because we hope it will lead to a diagnostic test, and hopefully it will identify some targets for treatment in the future. So we recruited 200 women from our clinics in the UK, and we published the results in 2022, and then collaborated with colleagues looking at the UK Biobank data. And just because we don't have much time, I will condense all of these research efforts into one slide. Before I try and present the data, it's important for us to know that we all have genetic mistakes in our DNA. That's what makes us different, and not all these genetic mistakes cause diseases. So when we analyze the results of whole genome sequencing, we're going to find lots of gene mistakes in everyone. And the tricky part is working out which of those gene mistakes, if any, are actually causing lipedema. And so we compared the DNA mistakes in all the women, and we found that many of them shared mistakes in these genes, and these 18 genes were quite interesting. And then 2 of them appeared to be associated strongly with lipedema. So there's the VEGF-A gene, which plays a central role in the formation of blood vessels, and the GRB14-CoBLL1, that's a gene involved in regulating metabolic processes that can influence fat distribution and insulin sensitivity. So we've got some candidate genes here that are very exciting, and we're working with colleagues to look at their patients and see if we can find the same gene mistakes in those women, but we need more numbers to prove that these mistakes are real. So the summary of our study so far is that we've identified these genes of interest. We've got more genes to discover. We're making progress, but it's frustratingly slow. But we're going to keep researching because, as you'll learn from this afternoon, we need tools to make an early diagnosis. But working in research just makes you realize so much more research is needed in lipedema. So many questions that we have to answer. Why does lipedema develop? Is there a genetic cause? I would say yes, but I don't know what the answer is yet. Are the fat cells different in lipedema compared to normal fat, obesity fat? What is the link with obesity? Is there an association with inflammation? Does lymphedema develop in some patients, and if so, why? Is there an underlying lymphatic problem, like in genetically determined primary lymphedema? Research and collaboration is urgently needed, and we're making steps. So back to the clinical aspect of lipedema, just going through the symptoms and signs of this condition. What are the symptoms? What might women with lipedema be experiencing? Pain. Pain is key, but pain is subjective. Some women might say their pain is mild. Some women might say their pain is severe. Some might report it as heaviness rather than, a sharp stabbing pain or a heavy aching pain. But tenderness and easy bruising are also features that are often reported in the clinic. Persistent, disproportionate limb enlargement, despite the use of compression garments or weight loss. So if this is someone has limb swelling from fatty tissue from obesity, you would expect a generalized loss of fat with weight loss strategies, but that doesn't happen in lipedema. These women can lose weight much easier from their torso than they can from their affected limbs. And if the swelling was due to fluid from lymphedema, we would expect the limbs to reduce with compression, and that doesn't happen in lipedema. There may be associated symptoms of hypermobility, knee aches and pains. There may be an overlap with chronic fatigue syndrome symptoms and fibromyalgia. There may be some reduced functional ability, including mobility issues. Perhaps that's from the sheer size of the limbs or musculoskeletal complaints. And there's often a decreased quality of life, some depression and anxiety issues that perhaps haven't been addressed or explored why the women are struggling. The clinical signs of lipedema, as I said before, this excess disproportionate fatty tissue on the limbs. Often there's a low waist to hip ratio in lipedema without the presence of obesity. So if you take a tape measure and measure the waist and then the hip circumference and do the ratio, less than 0.8 would suggest this could be lipedema. Higher levels lean you more towards obesity issues when you have central fat deposition around the abdomen, which you don't typically see in pure lipedema. But as I said, some women with lipedema will get obesity, and then the waist-hip ratio sign is no longer helpful. The tissues are soft and can be quite floppy, so you gain consent to, please can I touch your tissues and can I wobble them? And lipedema usually have this very floppy consistency to the tissues, particularly on the thighs and the upper arms. Some women are convinced that their fat feels different. They have nodular or grains of rice or beanbag texture to the fatty tissue, but that hasn't been present in all the women that I've seen in my experience. The hands and feet are spared. That's key in lipedema, creating a braceleting effect where the fatty tissue stops and then the hands and feet are spared. And that's very different to lymphedema, where typically the foot or the hand in the swollen limb is swollen first. There'll be a negative Kaposi stemma sign on the toes, and that's for those of you that are confident in diagnosing lymphedema, where there's swelling of the toes and feet and you can't pinch the skin at the base of the second toe. There's no or minimal pitting edema on the limbs in lipedema. And then there's a staging system. Certainly if you Google lipedema, this is used quite frequently in many clinics across the globe. And I'm not quite sure where it originated from, but from having a look at the literature, I think it might have been Professor Schmeller and Dr. Karen Herbst that described the stages of lipedema. And I have some concerns about using it in my clinic, as it makes a lot of ladies living with lipedema worry that lipedema is a progressive disease despite their best efforts, and they're very worried about what stage they are when I make a diagnosis for them. And it doesn't take into consideration pain or other impacts on quality of life. But it does have its use for the patient, especially if they're seeking liposuction surgery in Germany. The surgeons operating there often require a stage and a type of lipedema before they can be offered treatment. So I will include this in my diagnosis letters, but it's more to aid the patient in accessing treatment. And here's a cartoon picture of the stages of lipedema, and here's what it can look like in real life. So stage 1, where the clinical signs are subtle with excess fatty tissue in the limbs, but the skin is relatively smooth. In stage 2, the skin's a little bit more uneven, with sort of indentations around these medial knee fat pads and clearer ankle braceleting here. Important to note the feet sparing in this patient. If we follow the staging definition, both these women fit into stage 2, but in the practical sense in clinic, their symptoms and quality of life scores are very different. So the stage doesn't really relate to the struggle these women are having. And here's an image of a lady with perhaps stage 3 lipedema with more significant disproportionate fat deposition. We mustn't forget the arms. They're often not discussed in the staging system, but certainly they do affect our women in clinic. And there's this stage that's used by many physicians that I disagree with, and stage 4, development of lipolymphedema, so the presence of lymphedema. And I really don't like this stage 4, I'm afraid. I'd like to see it removed from the literature. Using the staging system, we're unable to consider if the lymphedema is due to obesity, varicose veins, or other factors. I don't think we can say that lipedema causes lymphedema. It's more likely that other factors going on, such as the obesity or the varicose veins, are the underlying cause of someone's lower limb lymphedema. But more work needs to be done to understand this. And then we've got the types of lipedema, and shaded in are the different tissue regions affected by lipedema, abnormal fatty tissue depending on the type. And again, I'm not sure it really adds to the diagnosis for a lady with lipedema, but it might be a useful tool for physicians to communicate between clinics about a shared patient. So if you can say it's stage 2, type 3 and 4 lipedema, you can visualize which areas of the body are affected and how we can try and help these women. But again, I think more work needs to be done in an international agreement on the signs and symptoms of lipedema and how we can confirm a diagnosis. So differential diagnoses that are often considered are obesity and lymphedema. And there are some tables coming up here trying to compare the different clinical signs between obesity, lipedema, and lymphedema. And the key thing for lipedema is that it is symmetrical. If there's asymmetry, it's more likely to be a lymphedema problem. And in pure lipedema, the feet and the hands are spared. Weight loss can reduce the limb volumes to some degree, but it's slower compared to weight loss from the torso. And further on here, just talking about other signs and symptoms between the three groups. I'm just conscious of the time because we started this session a little late, so I'm going to move on. But this is quite a powerful image comparing lipedema and lymphedema, so the two conditions that are often confused with each other. A lady with lipedema on the left has symmetrical increased limb volumes. You can see her feet are spared, so she does not have lymphedema there. You can see the bruise on her shin. You can appreciate perhaps that the tissues are soft and floppy just by the contouring, and you can see the medial knee fat pads, which I think are quite a classic sign. And then the patient on the right is known to me with primary lymphedema, so there's asymmetrical swelling. The feet are very swollen, and trust me, if you pressed hard with your thumb on those shins for 30 seconds, you would leave a large dent because the cause of the swelling here is lymphedema fluid, and you're able to shift that with pressure, whereas you can't manipulate a fat cell with pressure. So the pitting test is negative in lipedema. So how can lipedema be diagnosed? Well, it's a clinical diagnosis, as I've said, but I think it is possible to make the diagnosis if you take a detailed history and you perform a thorough clinical examination. And we heard from the patient stories that perhaps many of them aren't being examined in clinic, but I think from visual inspection, palpation of the tissues with consent, and perhaps taking a waist-hip ratio can just guide you to making a diagnosis. We don't have diagnostic tests at the moment, but maybe the future will include a genetics blood test. That's my goal in my career lifetime, to achieve that. And, you know, imaging, at the moment it's done in the research setting. We haven't got any NHS tests to confirm or exclude lipedema, but the future might include various tools like MRI, ultrasound, DEXA scans looking at the fat components, CT scans, or maybe even lymphatic imaging, depending on what our research outputs are. Common diagnostic pitfalls that I think are encountered by medics are, you know, rushing to make a diagnosis of obesity or lymphedema, perhaps not taking the time to ask, if, you know, or listen to the story of pain being a real problem. Lymphedema is heavy and achy, but lymphedema doesn't hurt, and obesity doesn't hurt, but lipedema is painful. Perhaps not considering that hormonal link and the family history, and not performing an examination. And we're trying to improve education on lipedema. You know, we're now getting it on the medical school curricula in some universities in the UK, so hopefully the future will be better for patients. Just a reminder again of the clues for lipedema: symmetrical abnormal fatty tissue, sparing of the feet and hands, soft floppy tissues, no pitting, but they could be tender. Think about that low waist hip to ratio, and then the history of disproportionate weight loss. So when they've tried to lose weight because they've been told that they've just got obesity, they can lose weight from the torso, but not so easily from the limbs, and this can differentiate from obesity. And they don't report increased episodes of cellulitis infections like you would expect someone with lymphedema to have. And if they've had access to compression garments, they won't say that their limbs are significantly reduced in size as a result of wearing them. So how do we manage lipedema? Well, weight management is key. There's a lot of misinformation out on the internet that weight loss has no effect on lipedema limb volumes, and I've been fighting against this for years in my clinic. But one of our recent papers, we tried to address this. So we were assessing 200 women with lipedema and asked them about the effect of weight loss on their lipedema limbs, and only 7.8% of women said that weight loss dieting had no effect on the limb volumes. 86% said that they could lose weight from their limbs in a disproportionate rate, and 5% felt it was an equal loss. So if you are struggling with being overweight and having lipedema, losing weight should provide some benefit to the limb volumes. And there's also increasing anecdotal evidence that the GLP-1 agonist weight loss injections are effective in reducing limb volumes and also pain for many women. And I think they're also likely to help prevent post-liposuction recurrence of lipedema fat deposition, perhaps via their weight management effects. Avoidance of weight gain should prevent significant disease progression. And that's, another reason for getting an early diagnosis. And current views shared by medical professionals are that weight gain is the likely cause of progression. And colleagues in Spain published this paper this year, trying to assess if lipedema was a progressive disease, trying to address those concerns on the internet. And they have 100 patients that they followed up for 4.5 years. And they were looking at percentage volume change in the limbs as their endpoint, and felt that progression could, occurred if the limb volumes increased by 10%, and then improvement if the limb volumes decreased by 10% or more. And you can see from the pie chart that 10% of women improved, so they lost limb volume measurements, and 62% remained stable, and only 28% progressed. And they looked at other factors and noted that those that progressed, that was associated with a change in BMI and a change in waist-height ratio, so the increase of fat around the abdomen. So their conclusions were lipedema was stable in the majority, progression was related to abdominal fat gain, and age and the use of compression didn't impact whether someone remained stable or not. So that gives us more evidence to be confident saying that weight management is really important for women with lipedema. So what else can we talk about for management? Well, compression, it may reduce pain. That's why I think everyone with lipedema should be offered a trial of compression, but it can't reduce limb volume size if they've got pure lipedema and no lymphedema. And it, to the best of my knowledge, can't prevent disease progression. You'll hear from colleagues more about compression types in a bit. And then it's really important to encourage women with lipedema to exercise, both for physical and psychological benefits. And we need to ensure that they have access to psychological support, because they do struggle. They have a really difficult time with things and don't get the help that they deserve most of the time. We're often asked about, any specific diets that will be helpful, any supplements, but there's no robust science about any of that yet. And then briefly just touching on liposuction. This can reduce limb volumes from lipedema and reduce pain in many, but it's not a cure. Lipedema can recur, especially in the presence of post-operative weight gain. And as many of us are aware, it's not currently offered on the NHS. So does an early diagnosis matter? Yes, I think it does. If we don't have an early diagnosis, there's problems with persistent and progressive pain, and the fat deposition will increase if somebody isn't aware they need to manage weight. And there'll be issues with mobility and functional decline and psychological burdens and healthcare costs to the NHS. So I do think an early diagnosis is important. We must prevent misclassification as obesity for so many reasons for these women. And an early diagnosis enables early intervention. Compression and physiotherapy can reduce pain and improve mobility. Weight loss could improve the lipedema, certainly prevent disease progression, and hopefully would improve some mobility. And liposuction, if they can access it, is likely to achieve better outcomes, perhaps if it's offered before the limb volumes are really excessive. An intervention could reduce the psychological burden of disease and improve long-term quality of life. So thank you very much for listening. The summary of my talk is that there are still many challenges for the lymphedema therapist and clinician, as well as the people living with lipedema. Frustratingly, we don't have a diagnostic test yet. It's currently a clinical diagnosis. Obesity and lymphedema can complicate the picture, and I appreciate that can affect quality of life. These all need addressing alongside management of lipedema in these ladies. We need to encourage medics to focus on the history if the clinical picture is confusing for them. The lack of diagnostic criteria amongst clinicians is still sometimes a problem, but that's something the Lipedema UK team intend to improve, and they're working on it. And more research needs to be done to understand the disease better, and in time this will lead to better treatments and hopefully a cure for lipedema. But we're going to keep striving for an early diagnosis, as this will surely improve the outcome for women living with lipedema. Thank you very much for listening.
Thank you very much indeed. Not just only just a great rundown there of what lipedema is and why early diagnosis is important, but on a personal note, Christiana, just showing what a great patron you are for Lipedema UK. So thank you very, very much indeed. I was particularly interested in the genetic developments, but of course, however much genetic progress there is in finding out the cause of this, if there's no treatments out there, then women are still going to find it very, very difficult. So let's move on to that now. And I'd like to introduce Dr. Anne Williams. She's a lymphology specialist and she runs a private practice in Scotland called ESK Lymphology. And I hope I pronounced that right, Dr. Williams.
Yes, you have. Thank you, Suzanne. Thank you, everyone, and welcome to this virtual room. It's lovely to be here. I'm just going to share my presentation. I've been asked today to speak around the title Mind the Gap, where conservative therapy falls short in current NHS services. And I think we've already heard, thank you so much to the 4 women who spoke at the beginning of the conference, and we've already heard perhaps some varying thoughts there from Sue, who felt quite isolated and had gaps in her service, right through to Charlotte, who spoke about the care that she had from St. George's. So what I'm going to try and do is to look at some of the evidence around the gaps and problems for women. I'm going to look at some of the literature, and I'm going to talk a bit about conservative therapy and what that involves. And then I'm going to finish by looking at posing some questions for us to think about. And by conservative therapy, I'm talking here about the approaches that are non-surgical, non-pharmacological. And if I was to ask you, all the different people in this room, what are your experience of the gaps or the shortfalls in lipedema support and conservative therapy throughout the UK? You may have a very mixed list. So there may be women in the room who've had lipedema for many years, who have quite a long list. You've maybe had difficulties like Sue accessing support, like Sandra having limited coordinated care, or indeed you may be like Charlotte, you may have had some very good experiences of your NHS conservative therapy. So, but of course, one of the things, and it's perhaps worth noting this from those who are perhaps outside the UK, who are coming in from outside the UK, that in the UK, the health services are devolved, and so the management and organisation of service and funding of services across the NHS in England, Scotland, Wales and Northern Ireland is different, is done differently. So already we've got discrepancies across the different countries and within the countries. So again, that's quite an issue for us, starting to look at how we can standardise what happens for these women. And also there may be doctors in the room, those involved in setting up services, interested in setting up services, who are asking questions around, right, where are we with evidence-based medicine in lipedema? And we go back to some of the early thoughts around the components of evidence-based medicine, which are still relevant here. And as Christiana said, we know that we're still very limited in terms of the scientific evidence that we have. And perhaps for many people in the room, the clinical judgment and the opportunities to learn about lipedema, to be able then to make clinical judgments and decision making is fairly limited at this stage. But what I would like to say is around the values and preferences and issues for people, well, we do have no lack of evidence about the problems for women and the gaps. And in this slide, I have listed 8 studies that have been done. 7 of these are from the UK, and 1 I've pulled in from Sweden, recently published from Sweden. And what you'll see that over 10 years ago, Shari and Amy Fetzer were both involved, and Lipedema UK were involved in this big survey, which involved 250 women. And then from then on, you'll see a number of different studies that have been done. You can see that Mary Warrilow recently had published on quality of life survey of over 900 women, and you'll see that also more recently Fetzer and Hill have undertaken 2 surveys that have involved healthcare professionals And again, Gary Cooper and the team undertaken a focus group with 60 healthcare professionals. So there has been a lot of work that's been done. And in fact, in Scotland, we were involved in undertaking interviews and focus groups and looking at experiences of women with lipedema. And again, a couple of other studies that have looked specifically as well at compression and the experiences of compression therapy. So there's really no shortage of evidence. And if you won't be surprised to see that the common themes that have come through here are things that you've already begun to hear about: the delays in diagnosis, sometimes many decades, the misdiagnosis, poor management of physical symptoms such as pain and mobility, which of course is so key. Conservative therapy is so key here. The problems with conservative therapy options such as compression. Christiana has mentioned that already, and this is a really key area which I'll touch on again in a minute. But I've put a couple of images here where you can see two women with lipedema in two very different types of garments. One of them on the left is an off-the-shelf garment which the woman can buy herself. The other one is quite a complex made-to-measure, custom-made garment, flat neck garment used to manage lipedema. And so you can see that again, we've got a potential for problems in how these garments are available to people and how they're measured, and we've also got a situation here where we could have, if we get this right, we can have a very effective system that saves money. But at the moment, despite the fact that industry have worked very hard with practitioners and with women with lipedema to develop these different garments, we still have potential for problems in people accessing the right garments. And there possibly be many people in the room who've had experience of these issues. And as Christiana touched on, the limited support potentially, or the need for support with mental health and emotional psychological challenges. And from my experience, certainly these are made worse if a woman has symptoms and problems with lipedema that are not taken seriously. So just to touch on a little bit of detail from a couple of these papers, you can see if you scan down Mary Warrilow's paper here, you can see the tremendous problems that people are having. High numbers of people with mobility issues, with fatigue, with different physical problems in managing weight. And you can see already that the need for conservative therapy and really quite complex, important, specialized conservative therapy is really important here. You can see that mental and psychological health, so already, say Christiana's touched on this, the need for psychological support comes through very clearly. And also I would say in terms of work, home life, we've got here now a group of women who are young, who have families, who have jobs, who have a really important socioeconomic impact on the UK, and we need to do what we can to support these women with compression therapy to be able to manage this condition better. So now this slide is interesting because, and what I want to point out really is that we're now getting some information from healthcare professionals. So where some of the early studies were looking at the gaps and the problems for women, for example, the limited access to specialists and the limited sort of options for conservative therapy and self-care, the fact that they're having to buy their own garments, etc. We've now got evidence coming through around the problems for healthcare professionals. And this is really perhaps quite key because we can see these real discrepancies. We can see now that healthcare professionals are lacking confidence in diagnosing lipedema. You can see that there's a need here for education or training. There's real gaps here. We can see also that generalists are perhaps not seeing people with lipedema very frequently, so it makes it very complex. It's much easier for perhaps us who see people in clinics every day to recognise lipedema. So I think we have to understand that this is very difficult in a general practice, for example, where the GP may not see somebody with lipedema that often. I think what's come through in this study as well is the lack of specialist services and the limited options that people have to offer. And then if I just jump to Gary Cooper and the team in Wales have published a lovely paper just recently where they looked specifically at the experiences of health professionals. And I think this is very telling. They did focus groups with 60 healthcare professionals. And we can see here again, similar themes coming through, the challenges for them, the gaps in resources, the professionals feeling inadequate because they don't really know what treatment options there are that they can use to help these women, and the emotional impact on the healthcare professional. So I think we can see that there's a real need now to start to get this right and to start to look at how conservative therapy can be developed. So I want to take you back to the best practice document that we developed in 2017. Now, these were guidelines that we developed with Wounds UK. And I think the key principles that are in this document that are on the left here are still relevant today. And I wanted just to bring them to your attention. So if you're involved in developing a service for people with lipedema, there are perhaps these three things that need to be in some way your guiding principles. You need to look at how you can facilitate and enhance self-care for women with lipedema. You need to be looking at optimization of health and preventing progression. And obviously that very much ties in with what Christiana was discussing earlier. And then we need to look at how we manage symptoms such as pain and coexisting edema and psychological challenges. And when we wrote the best practice documents a few years ago, and they are in some way out of date, but some aspects are still relevant, we looked at psychosocial support and management of expectations as a really key area here. That was one of our first sections that we discussed, because getting this right and listening to women and helping them begin their journey through conservative therapy is so key. And it takes time, and recognizing that this is one of the difficulties, particularly in general practice, that is a difficult point if you have a very short time with somebody. But actually, even the acknowledgement of being able to refer someone on and start to look at these key components for them is really key here. So, but what I'd like to now just draw attention to are the guidelines from Germany, because I think they've taken us a step on. And in terms of conservative therapy, the assessment obviously is so key. And the German guidelines are beginning to draw our attention to what we need to do in terms of biometric data. And again, quite clear from what Christiana was discussing, how waist to height ratio is really more important than BMI, which has been traditionally used a lot in the NHS. Psychological factors, again, being assessed here, and the cause of lipedema progression. So again, you can see these German guidelines that are really reflecting a lot of what Christiana was talking about earlier. What I think is really key as well is that they talk about the use of compression therapy for pain management. And they cover quite a bit of detail on the issues of selecting effective pressures and the right pressures, the right materials for people. And this, of course, is quite a specialist area. This is quite a challenging thing for people to be making this assessment, measuring, making decisions on what compression is right for one particular woman. It may be different for someone else with lipedema. So again, these are really key areas where at the moment I think the NHS is falling short. It's part of conservative therapy. These garments are available, but at the moment, if you often talk to people with lipedema, you will find that they've had garments that have been measured but don't fit, that have cause particular problems. So this is a really key area for anyone looking at developing a service. How do we get that right around compression therapy? There's lots of debates around other areas of manual lymphatic drainage and physical movement. And certainly manual lymphatic drainage is used much more widely in Germany and not really in the literature in the UK, although it is clear that it is helpful for some women. But I really like that phrase, self-management is promoted and supported while responsibility remains with the person. And I think that's the thing we need to take away with us, thinking that what we're doing here is not just leaving somebody in the lurch. We're not just leaving them to do their own thing. We're actually finding ways to allow them to self-manage in effective ways while they don't feel isolated. Very similar to what Charlotte said earlier on. She was discharged from care, but if she needed support, she could get back in touch. And at the moment, if people are referred to services, one of the difficulties is that this may not be a long-term arrangement. So at the moment in the UK, current services are very varied, and this is one of the real shortfalls. There are differences, as I already said, across the different areas of the UK. And the GP is a key first contact, but I think it's important, and Lipedema UK already noticed and recognised and have been working with midwives, because of course there are many other healthcare professionals who may be a useful first contact, helping a woman realise that she has lipedema. At the moment, one of the problems in the UK is that we mainly refer to a lymphedema service. So if a GP recognises someone has lipedema, they may be able to refer on to a lymphedema service in the NHS. But one of the real questions around this is lipedema management may require a different approach. And whereas practitioners in lymphedema services have a lot of the skills that are required, there's some questions around this that we need to start thinking about. How could we do this differently? There are other questions around who else could be involved. So I'm going to just, aware of the time. So I just want us to think and leave this with you around, what would a multidisciplinary approach for conservative therapy look like? What are the options? What are the opportunities? And if we think of 3 key areas, diagnosis, investigation, who would be involved in that? If we look at referral for what we might call therapeutic support, what might that involve and who does that and where? So at the moment, it's probably fair to say that that is quite disjointed and not coordinated, as Sue said. So again, seems really key that we begin to piece together a much more robust and comprehensive service for people. And we also look at how, over the long term, we would support people to set realistic goals and make a plan and support lifestyle changes. So there's some questions to consider about conservative lipid therapy and lipedema, and we need more research. So things that we might think about: how do we best support women with lipedema at key points before, during, and after their diagnosis? How do we help them make and maintain long-term changes in their lifestyle? What does an effective and supported lymphedema service look like? How might a lipedema pathway support an accurate diagnosis and appropriate referral within a multidisciplinary approach? And this is something that Lipedema UK is working on. I think another question we need to think about: what creative approaches to self-management support would be effective for women and provide value for money? Can we, for example, use group support or other ways of bringing people together, for example, in the third sector? And how do we support healthcare professionals to improve their knowledge, skills, and confidence? So I'd like to go back just to finish with back to Gary Cooper's work and the team in Wales and say thank you. They just published this recently, and I think these are really important ways forward, and this is their conclusions. And I recently went up Yrwythfa, I think I pronounced that correctly. Might be Welsh people in the room who would tell me. It used to be called Snowdon. And I was thinking of this is us kind of climbing this mountain to an extent. But the team in Wales have suggested we need standardized diagnostic tools, we need evidence-based guidelines, and above all, we need an interdisciplinary collaboration to support effective and empathic care. And I think that really, those two words, effective and empathic care, are the way forwards to try and bring a much more to address the shortfalls in conservative therapy and bring a much more comprehensive approach to this. So here are my references, and thank you for listening.
Thank you very much, Dr. Williams. So we've had two super presentations and of course the patient videos. So now let's move into a panel discussion. And also joining us for the panel discussion is Sue Bellingham, who was one of the voices you heard in that video at the beginning. So we've got Professor Christiana Gordon, Dr. Anne Williams, and Sue Bellingham. We've had lots of questions in the chat. If you've got a question, do please pop one in there. I'd like to start off with one of my own, if I can be very selfish and do that to you, Professor Gordon. You talked about how weight gain is a major factor in the progression of lipedema, and I'd certainly second that. But a lot of women also find that hormonal changes really send it haywire as well. For my own part, certainly being pregnant, the lipedema got a lot worse. Is that something you find is very common? And is there anything you can do in those situations to try and help yourself?
Tricky question, thank you.
Sorry.
No, it's fine. It's fine. Yeah, certainly from the patients that I see in clinic, the feedback that I'm getting from my questioning is that hormones play a significant role in weight gain or exacerbation of lipedema. And I think hormones themselves probably encourage weight gain. Women that don't have lipedema but perhaps go on the birth control pill will often report that they've gained weight. So I think perhaps the double whammy of puberty, weight gain, going on the pill, all contributes. We frustratingly really don't understand the science yet behind hormones and lipedema. In some basic sort of hormonal research that we did on our patients, where we did sort of standard hormone panels of estrogen, progesterone in women with lipedema, we didn't find any abnormalities. So it's going to be a tricky one to crack, to understand that link. There's some exciting theories out there at the moment. There's one academic physician that I was chatting with earlier in the year, and she has a theory that it's the estrogen acting directly on the fat cells that is triggering increase in tissue volume. So that would be an exciting thing for them to look at. But what can someone in real life do as they go through puberty, or if they need to go on hormonal therapy? I mean, it's really hard, isn't it, for all of us? If you feel hungry, you want to go and eat, and it's hard to not listen to those voices and to manage what you eat. I am a big fan of the GLP-1 agonist weight loss injections. Not saying that we should be putting all teenagers on them, but if somebody's in a situation where their weight is climbing despite their best efforts, and perhaps that is being exacerbated by hormonal therapy that they need to go on for whatever reason, be it HRT or hormonal therapy for cancer treatment, then perhaps we should be discussing these weight management tools sooner than we are in reality. Did that answer your question?
Yeah, there has actually been a lot of questions about the role of estrogen in the progression of lipedema. So it seems to me that what you're saying is really we just don't know, but there seems to be a connection, but we're not exactly sure what it is.
Exactly.
Yeah. So also the issue of weight loss drugs has come up, and I know we're going to be talking about that in the next session too. But there's a question here: is there a possibility that lipedema will be listed as a relevant condition in order to be prescribed those drugs on the NHS in future?
I would very much like to see that happen. We are in discussions to try and get that to happen. But for those that work in the NHS, you'll understand the red tape that we're experiencing. So it'll be a slow journey, but I would very much like to see lipedema on that list.
Okay, thank you very much. So a couple of questions possibly for you, Dr. Williams, about conservative therapy. So I've got two questions here. One about just actually how useful is compression on lipedema, Can it reduce the swelling? I think you already mentioned that the answer to that is no. But are there other ways in which compression can be useful? And also, I think there's some debate, isn't there, about whether or not compression is helpful or not after you've had liposuction for lipedema. Perhaps you can tell us a little bit about that.
Yes, thank you. Thank you for the question. I feel, and I think I touched on what the German guidelines are saying, and I think compression has got a really important role in lipedema. And I think it particularly, as the German guidelines say, for pain, for managing pain. So I would always encourage someone with lipedema to look at the options for compression based on whatever symptoms are a problem to them. And I think probably if you're looking at a sort of spectrum of options through from the compression therapy that can be bought off the shelf, if you like, can be bought. There's certain types of garments that can be bought that I showed on screen there. It can be bought without a prescription. And then there are a whole range of different garments that can be bought on that can be on prescription, from right the way through to compression club, flat knit compression class 2 or 3, right, and also some round knit ones. So they're made differently, and there's a whole range of different ones available. So I would say that compression is useful. My experience is that a lot of times people find if it's well fitted and it's the right thing for them, that it is very important, it is useful. And if, as Christiana was saying, we don't like the term lymphedema or lympholipedema, but in actual fact, if we do have somebody who's got an element of edema associated with the lipedema, and so they have experiences of a buildup of fluid, for example, makes their legs very heavy by the end of the day, I would recommend compression for them. But I think the key thing is to get the right advice about it, get it properly fitted, get it properly measured. And I think that it's certainly, I think that's a real thing that we're working on already. We've had some discussions at Lipedema UK about that in terms of the pathway. I don't know if you want to come in, Christiana, and say anything here.
Yeah, I agree with everything you've said. I think maybe what I'd add is I think one of the components of the question was how about compression post-surgery, and I'm very keen that women undergoing liposuction for lipedema do have access to compression post-surgery as a minimum, because that procedure is going to cause a lot of inflammation in the limbs, potentially cause a little bit of disruption to the lymphatic system, and the use of compression will improve lymphatic drainage. And we know that the lymph system is key in regulating inflammation. So we're confident that the use of compression post-operatively will stimulate lymph drainage, reduce inflammation, expedite healing, reduce risk of post-operative wound infections. So I'm a real advocate for post-op compression at the very least.
Yeah, I absolutely agree. And I just saw 2 women this morning actually who are in their compression after liposuction and doing extremely well. So I would say definitely I agree. And I think the key thing is, and some of the, and this is where we have some shortfalls, because we have a situation perhaps where somebody's going for liposuction abroad, and then the NHS service will say, well, I can't measure you for compression because you're going abroad for your treatment. And this is where I think there's some work that needs to be done to work out, how we make compression available to people, whatever the situation. I think it's wrong that there's some sort of way of excluding people from compression, because ultimately compression is going to be important to them in the recovery, as you say, Christiana, reducing inflammation and preventing any possibly rebound edema or recurrence of the lipedema. So yeah,
absolutely. Sue, what's your experience of compression? Have you got anything to add?
Personally, I haven't used compression. My experience with trying to get a diagnosis from my GP has literally put me off going back. And I think for me, one of the big issues was that if I did go back armed with some of the information that's provided for us as patients on the Lipedema UK website, that my personal feeling is that I still probably wouldn't get the referrals that I needed. So I think what I'm saying is I haven't been back. I don't use compression. I should use compression. I know this. But I think now with the NHS right to choose system that's in place, I would be more likely to go back to my GP and ask for a referral to a specialist like lipedema center somewhere around the country, because I know there are some, to get fitted with the correct compression garments. So, I mean, the simple answer is no, I don't use compression, but I would like to use compression. So that's something that I need to address.
Okay, thank you. Yes, it all comes back, doesn't it, about raising awareness, about making sure that there's that patient support in place that you clearly haven't had, very sadly. Okay, well, let's move on. Very different question. I was very intrigued when in the patient story video at the beginning, Pia talked about how people blamed her big legs on her culture. And we've got a question about that here, saying that women of African or Caribbean heritage are traditionally known to have larger legs and bums. Not sure that's always the case, but this is the question. Could this be due to lipedema? And are there any studies being done or in the pipeline into whether your ethnicity could make you more prone to having lipedema? So I'll throw that open to the whole panel.
Would the panel like me to have a go? Yes. So there's sort of two parts to that question. Could large bums and thighs perhaps be lipedema? So that's a really difficult one to answer, and it's also difficult for me to not put my foot in it and say anything inappropriate, so I'm sorry if I do. But I think my understanding is that there's a condition called steatopygia, which is the medical term to describe the large buttocks and hips of African women. I think, we think of the Hottentot tribe as one group of women that were investigated with this. And could that be lipedema? I don't know is the honest answer. I don't think the doctors researching that 30, 40 years ago would have considered that. I suppose the way to break it down is that sort of cultural excess fatty tissue in those areas. Is it lipedema? If it's painful, then I think it could be. But my understanding of that steatopygia condition is that it wasn't painful. And from my limited understanding of that diagnosis, that was thought to be occurring as a mixture of sort of genetics, and it was something that occurred in that region, and was a phenotype, a body characteristic that was selected in a positive manner for potentiation of the species of humanity in that region. But in today's society, lipedema, so painful fat disorders, can affect women of all races. Unfortunately, women of colour have been neglected in taking part in research studies. We're guilty of that in the UK with our genetic studies. We have specifically selected to only look at the DNA of white British women, and that's simply because we need to exclude any outliers in the genes that will just confuse our data. So we wanted to have the narrowest group of women to assess to ensure that any findings we discovered, we would be more confident they were due to disease rather than perhaps due to ancestral things across many different nationalities. I am not aware of any genetic studies at the moment or anything published in the literature specifically looking at lipedema cause or incidence and prevalence in different women, from their cultural backgrounds. I believe that the Lipedema Foundation maybe did a questionnaire study earlier in the year to their cohort of Black women living with lipedema, but I'm not aware of any published results from it. So yeah, I'm sorry, but not enough research has been done to explore this. We need to do better.
So I suspect the next question might fall into that category as well, but I think it's a very interesting question about whether there's been any research in the trans community. So we know that lipedema affects almost exclusively females.
Yes.
But what happens if you're a female who has a testosterone? Will that slow lipedema progression? If you're female, if you're a male to female, are you potentially likely to get lipedema? I think that's a very interesting question.
Yes, it's very interesting, and not one that we can answer because the numbers aren't big enough. So in the St George's team, I would like to think perhaps we're seeing the most number of women with lipedema. We only have one trans patient with lipedema on our books. So I can imagine that these patients are probably going to have an even harder time getting a diagnosis, and their journey is going to be even more complicated. So we simply don't have the numbers to be doing any research at the moment. It's very much anecdotal stories that are incredibly interesting to us, but potentially have the power to unlock, really important answers to those questions about hormones and genetics together in one go.
And another question, hormones are a big theme on the chat. What about HRT? Does that potentially cause lipedema to progress? Is it better for women with lipedema to avoid HRT?
Yeah, the honest answer is we don't know. I'm asked this question an awful lot in my clinic. I'd say that we can confidently say that hormone therapy of any type seems to be associated with weight gain. And we don't know whether it's just weight gain that causes lipedema to progress. Could it be weight gain triggered by the change in hormone from hormonal therapy that causes it, or is it the hormones themselves? We don't know. So if a lady's sitting in front of me saying, I don't know whether to go on HRT, I say, weigh up the risks and benefits. If you are really struggling with menopause and there are horrendous symptoms that are ruining your life, and your GP or whoever's looking after these symptoms for you is confident that HRT therapy is going to improve your quality of life, my advice would be to trial it, but be mindful about your weight during that time. And if we need to then consider the GLP-1 agonists, if other sort of non-pharmacological strategies for weight management are failing, that's how I would approach it. I wouldn't say to a woman who's really struggling with menopausal symptoms or other reasons that she needs to consider hormonal therapy to avoid it because she has lipedema, just in case. But that's my personal view. We've got no science yet to back it up.
Thank you. Okay, let's talk a little bit about surgery. I know we've talked about conservative therapy, but there is a question here about liposuction, which I have to say I've benefited from enormously. But how easy is it to get liposuction in the UK? I went to Germany for my operations. I mean, are there competent lipedema liposuction surgeons in the UK who you'd recommend, and how expensive is it, I suppose, is the other question that people might want to know, because it's not available on the NHS.
Anne, are you happy for me to take this one? Yes, there are a handful of surgeons in the UK that offer liposuction for lipedema, but it is a handful. There might be several plastic surgeons out there who would be doing liposuction on women with lipedema, not realizing that they're operating on a lady with lipedema because they aren't aware of the condition. But there are a handful dotted around the UK that I would recommend in the private sector. But I'll be honest, they're more expensive in the UK, especially the ones based in London. London prices are extortionate. And so it's often, financially more sensible for my patients to look to Central Europe, Germany, Spain, Cyprus, where surgeons exist that are offering, really good surgical solutions for these women. So yeah, I'm not afraid to discuss surgery in the UK and abroad, and it comes down to the surgeon's experience and the cost.
Yeah, okay. So there's also a question about the ketogenic diet, which has been the subject of much debate in lipedema forums on social media. Would any of you like to mention whether you think there is any point in women with lipedema pursuing such a diet? Is it helpful or not?
I'll give my thoughts and then I'm very happy for anyone else to speak. So 5-10 years ago, when I was consulting with women with lipedema that were struggling to lose weight and they were overweight or obese, and we didn't have GLP-1 agonist weight loss injections. The only weight management strategies we really had were gastric bypass surgery or gastric sleeves, which these women understandably didn't want to rush to do. I was suggesting the keto diet because I do think for many people doing the keto diet, it is a very successful diet to lose weight. You cut out carbs and you lose weight. But the trouble that I then realized with the keto diet is that the moment you reintroduce carbs, the rebound weight gain can be catastrophic for these women. And that's physically and psychologically disastrous. And you can't realistically stay on a keto diet long term. So I'm no longer a an advocate of the keto diet for women with lipedema trying to manage their weight. I would, perhaps just say, let's try and do a low carb diet based on the patients I've looked after for the last 20 years. Really positive affirmation to women saying, if I eat a really high carb diet, I just gain weight so quickly. So I think things like bread, pasta, potatoes, rice, all those delicious beige foods seem to be really detrimental for women with lipedema. And that's something I think that's really interesting and could be explored in research a lot more. So no, I'm not a fan of the keto diet anymore, but a low carb diet I think is something that can be helpful for women with lipedema.
Okay, would anyone else like to comment?
Science.
Well, can I just come in quickly? I agree with you, Christiana, and I think this whole kind of concept of dieting concerns me a little bit as well, because I think we've got some interesting research from Scotland, from a study that was done in Scotland, where many women with lipedema, who'd had lipedema for many years, had history of disordered eating. So I think maybe needs to be some real thought into how we speak about food choices and healthy eating in lipedema. And I think that's a whole area, as Christiana says, that needs more work. Because I think restrictive diets are probably not healthy in the long term, because they're very difficult to stick to. And I think as a result, people then feel that they've let themselves down if they don't stick to it. So I think there's a lot to consider there.
Yeah, I think there's also the issue about restricted diets when you have lipedema and perhaps you don't know it, potentially leading to eating disorders as well, which is something that I know the big survey that Shari Fetzer did highlighted that many women with lipedema are so despairing, frankly, that they end up having eating disorders, so causing another problem as well. So we're running out of time. So two very, very quick questions. One, a completely new one on me. Someone's asking, is genital lipedema common? Not something I've heard of, but any comments on that? And also, is there any evidence to support the use of deep oscillation? You've literally got a minute.
I'll take the first one and take the second. Firstly, I've never seen genital lipedema. I've seen lipohypertrophy of the labia as an isolated condition, but never genital lipedema.
Okay. And any thoughts on deep oscillation?
Yes.
It's certainly lovely to have. I have tried it. It feels very nice, but whether it does any good or not.
I have to say, I have a machine. I do use it. As far as I know, there isn't good scientific research into deep oscillation. There's a great deal of anecdotal evidence, and I think I certainly find it's very useful for people with lipedema who have pain and after liposuction. So yes, I think it's something again that we need more research into.
Okay, well, thanks very much to the panel, and thank you all for your questions. I'm sorry I didn't have time to get all of them, but that wraps up the current session on understanding lipedema and a little bit about diagnosis and management. So I'm now going to hand over to Kate Forster, who's a trustee of Lipedema UK, for the next session, for session 2, lipedema management in primary care, challenges as primary care, emerging anecdotal evidence on GLP-1 medication, and the role of nutrition. So over to you, Kate.
Thank you, Suzanne. We've had a great introduction from our first presenters, and I'm delighted to take us through the next session, where we're going to start to dive into a couple of the things that were referenced. Dr. Anne Williams, in picking up on the kind of Fetzer and Hill recent publication about the challenges for healthcare professionals, referenced a number of pieces around just how challenging it can be to support people living with lipedema. So I'm delighted to be joined today by Leslie Steinitz, PhD, Dr. Nikki Maisie, and Dr. Gabriella Ferber. Dr. Maisie, in her piece, is going to take us through her experiences as a general practitioner and be able to bring in some of the overall tier 3 weight management issues. And Dr. Ferber, I'm sure, will jump into some of the conversation we had around nutritional approaches to lipedema management, as she's a coordinator and lead author of the German lipedema guidelines under the guidance of the German Society of Phlebology and Lymphology, in addition to having published on ketogenic ways of eating herself. What I'd like to do now is move on to Dr. Nikki Maisie. Dr. Maisie is a general practitioner herself and a tier 3 weight management lead. She's also someone who's done a lot with us in Lipedema UK and has a really great range of experience, because, as we heard in the first session, the challenges around where weight management fits for women with lipedema and where maybe it isn't always 100% the right thing, are definite challenges that people report and healthcare practitioners do too. So I am delighted that you are able to spare us this time today, Dr. Maisie, and I'd like to hand over to you to take us through your topic about how lipedema is hidden in plain sight and that we then face diagnostic and management challenges for that in primary care.
Oh, thanks very much, Kate. I'm just trying to share my screen. So I've been asked to talk about the challenges of
They've appeared,
diagnosing.
Nikki, just to let you know.
Oh,
It's also
brilliant.
just taking
Okay,
its
right,
time. So you're now perfect and all good.
Oh my gosh, I've never heard those words before, Kate, but thank you.
I'll
So
write them
yes,
down.
the challenges of, okay, so the challenges of diagnosing and managing lipedema in primary care. So I'm a GP, that's my main job. I'm a partner in a really big inner city practice in Liverpool. But I also specialise in weight management, and I work in a tier 3 weight management service for the last 20 odd years. I'm also the consultant for the eating disorders NHS service in Liverpool, and I've done that for even longer, about 26 years. So you think I'd know about lipedema with all of that, wouldn't you? I've got no statements of interest. I've got no conflicts of interest. So as a GP with my GP hat on, I think I'm so sorry to hear the negative experiences, which is all too common of patients with lipedema. And this I don't want this to sound like an excuse, but I think this might help understand why that might be happening. We have 0 undergraduate teaching on lipedema. We have 0 postgraduate teaching. So but that's not unusual. To compare that with eating disorders, there's at the most 1 hour of undergraduate teaching on eating disorders. So it's not that lipedema is isolated, the only condition we're not taught about. It's just that it's one of those that hasn't hit the radar, which is obviously something Lipedema UK and other charities and services are trying to work towards. So the most likely way that someone's going to come to my doorstep and teach me or pique my interest on lipedema is if they come in, it's an accidental discovery. Somebody comes in and says, something's wrong with my legs or something, and that should prompt me to find out more. And I'm trained to do that as a GP. I cannot know everything about everything, but I am trained to have an open mind and to try and find out more. But a lot of the problem, I have to say, I've been a GP for 24 years, 26 years. Patients generally don't seem to be aware either. And I know this group will be quite different, but I have never had anybody ask me, do I have lipedema, or I think I have lipedema. They've made a consultation just for that reason. The most likely scenario for me has been in weight management, where patients are struggling to lose weight. And I've gone, I wonder if, there's something else going on. Other problem is, who do I call? So if I don't know the answer to something, I'll phone a friend. I can email, I can phone if it's urgent, anyone in the hospitals to find out, but I don't know who specialises in this. Professor Gordon is unusual in their service down at St George's. That's not what we've got up in Liverpool or the Northwest. So I don't really have anybody to phone a friend for advice. Misdiagnosis risk. We're quite cautious about making a definite diagnosis, particularly something we're not sure about, we've never been taught about, we've not seen. We're relying on an internet search, possibly, because once it's on your records, it's on your records. And if we got it wrong, the potential that somebody might, for instance, go over to Germany maybe or another country, present for liposuction based on our diagnosis, and then be told, oh no, actually it's not lipedema, you've got it wrong, I think might be quite off-putting, quite scary for us as GPs. We don't want to get it wrong, but it's really on self-directed learning at this point. And as Professor Gordon said, there's no test to diagnose, so it's not like I can say, well, I'm not sure, but I'll do a blood test or a scan. And then the last point is the expert consultation. Somebody that thinks they've got lipedema, who comes in to see a GP who's never heard of it and is doing that classic, is it lymphedema? chat. They're really quite stressful consultations for us as GPs. Anyone who's the expert, whenever we're supposed to be the expert, you come to us, you're coming to me for advice, you're coming to me for my educated opinion on something, and I can't give it. You know, I may have never heard of it, seen it, don't know where to look for it, and can't speak to anyone about it. But you'll know more, and that is quite stressful. It feels bad. GPs, we're not horrible people. We're just maybe completely ignorant about this condition. So the internet is a wonderful thing and a scary thing at the same time. But usually the NHS website is the place for good, solid UK guideline advice. So that's where people can go, patients can go and have a look, and everything's on there. Sinusitis to, you know, my legs dropped off, anything. And I had a little look this morning I'd be current for lipedema and what it's advising. So this comes to the section on the difficulty I might have as a GP in managing lipedema. So the first point, if the GP thinks you have lipedema, they may refer you to a specialist for treatment. I've got no specialist to refer you to. Some parts of the country do have teams. Some parts of the country, the lymphedema teams are also very fluent with lipedema and can make a diagnosis and support. But our lymphedema team, they shut the doors to lipedema. They've also got BMI restrictions, so people who are above that couldn't go and see them. I think it was 40. So I don't have anyone to refer my patients to. The main treatments section, it mentions wearing compression stockings or bandages to reduce pain may make it easier for you to walk. So you'd hope that me as a GP, that I'd be able to get you that. That seems fairly basic, doesn't it? You know, measuring it for compression stockings, but it's actually a specialist thing, a specialist training to actually learn how to measure and to do it properly and accurately. I've never been trained in, I hadn't been trained in that. I'll come to one of my hopefully more positive sides, but I hadn't been trained in that. And my nurses hadn't either. I've got a large nursing team. I've got about 30 nurses in our team. And one of them had worked in the lymphedema service, but the rest of them hadn't done this before. And then at the very bottom, the procedure to get rid of the fat, liposuction. If your symptoms are particularly severe, you may need more than one operation and it may not be available on the NHS. Well, it's 100% not available on the NHS. And I think it's really misleading. I think I can understand why patients may feel there's an expectation that we should be referring and helping them access liposuction if that's what the NHS website's saying. So the information on compression says a specially trained clinician. Well, I've done one. I got one patient who was prepared to be a guinea pig and let me have a go with one of my nurses, with a lymphedema specialist nurse supervising us. I'd be delighted to prescribe compression if somebody was measuring up for it. I can prescribe 2 garments every 6 months, and there's no problem doing that. I think there's a misconception about GPs and budgets, and that we don't want to prescribe things that cost money. I don't care about the money, and no one else does. That's not really my direct issue. There is a medicines management team. There's a team of pharmacists, special pharmacists higher up who oversee the budgets in different areas and how much is being spent. But you know, it's not a cost issue. If somebody could get measured up, the issue is about getting the training and then getting support. So that's great. But I always think it's bad that we're relying on charities to provide education and information. I think the NHS, we ideally should also have a suite of support and advice to offer patients. Other difficulties around managing, obviously liposuction is not available on the NHS, but people living with lipedema may well decide to have liposuction abroad or privately. I've never been taught about liposuction. It again never hit the radar, and as per point 3, traditionally it has been perceived as cosmetic. That's not my opinion, but it has been perceived as cosmetic. And the differences, the nuances and the different types of liposuction used, again, isn't something that your GP will not have been trained on. Because it's not an NHS treatment as well. Again, it's seen as something that, you know, somebody could go off and do privately, and that's all been sorted privately, and we are sort of absolved of it, really. I've heard about patients being quite frustrated if their GPs won't even do the blood tests before surgery if they are going abroad. I personally would be very happy to do that, but if you're a rule sticker, then technically I don't need to do that. And also blood type sometimes people are asked to find out what their blood type is. You're not going to get that from your GP. In primary care, again, the frustration is, well, not frustration, but we do not do blood transfusions in primary care. So there is no form that I can tick to get you a blood type test. It doesn't exist for me. I don't have access to that. The only way to work out your blood type is to either give blood or get pregnant, or pay for it. The other thing is people going abroad for blood tests, coming back to the GP, and being asked to do tests based on what maybe their German or their Spanish or Polish surgeons are asking. They don't always correlate with our tests, and the values may have different ranges or have different parameters. So it might look a bit odd to the surgeon, the result they got from the UK. As far as side effects and complications, again, if we're not really very familiar with it, it's not something that's happening a lot in the UK, apart from infection, which, you know, I think is fairly barred, or for all of us in primary care, things like fat embolus or DVT, or the fluid shift, the electrolyte disturbances, that's stuff that's way beyond our level of expertise. And again, because it's a private procedure, we don't have to be involved in the pre or post-op care. So, but that sounds all very negative. And as a GP, I've used myself as a guinea pig and tried to make some changes. And I think it's been a very positive journey. I'm self-taught. I learnt about lipedema at a GP conference 9 years ago, when I was wandering between lectures, and out of the 200 stalls that were advertising various things, I spotted a stall that had a load of pictures of ladies' legs, and it sort of caught my eye, and I thought, gosh, why have they got pictures of ladies' legs? And it was Lipedema UK, and it was the first time that I recognised my own legs, my mum's legs, my sister's legs, my daughter's, you all get the picture. So I too have lipedema, but it also reminded me of the many patients I've seen in specialist weight management who had reached a point where they were potentially wheelchair bound, using sticks, really struggling with mobility. And I realised, gosh, you know, I've let them down. I've probably missed a lot of cases of lipedema, so I'm going to do something about it. So I've been on a bit of a journey, and I even attended the international conference 2 years ago in Potsdam, self-funded, and I do support Lipedema UK. Try and do some talks when I'm asked. And I've also done teaching in my practice. All of my clinicians, of which there are 70 of us, are all now aware of lipedema and the difference between lipedema and lymphedema and obesity. My nurses, who are a great bunch, independently got teaching on compression garment measurement. And I've made friends with our local lymphedema team, who are lovely and have been helpful where they can, with occasional patients. And I've campaigned that they open the doors back up to lipedema because we have nobody else. I also do teaching on eating disorders for the GP registrars, the juniors as they're rotating around. And at the end of every one of those talks, I pop a lipedema picture up and ask them to make a diagnosis to try and bring some awareness. It's a bit of a backdoor route, really, but I think, you know, anything I can do to raise awareness. The pharmacists may be able to measure up for compression. It's something that we're looking at, and that would be really easy if that is actually the case. Also developing a template for the GP computer systems, so that they don't have to think about what questions to ask if somebody comes in struggling with symptoms of lipedema. Then hopefully this will make this easier for them. And also housebound patients. I definitely think a lot of our housebound patients may have started with lipedema that's not been treated and have got into a position where they are housebound and in some cases bedbound. And I am campaigning for recognition for this with NHS England. So, this seems to have been covered by Anne, but I totally support, sorry, and the previous speaker, I'm awfully sorry, I don't remember your name. I totally support GLP-1 injection lipedema as tier 3. We are just starting to do GLP-1 at the Manjaro. We have done the previous GLP-1 2 years ago. We did 50 patients for that. That is part of our remit. However, it's coming to primary care. So as a GP, if you meet the criteria, your GP can prescribe. But the problem is at the moment that they are limiting the numbers, even though they modelled how many should be eligible on the NHS England modelling. And they have to be able to be referred to a digital wraparound service, and some ICBs that isn't yet set up, or there's some delay with that. But GPs basically are the first port of call. Those are the conditions that you have to meet to be able to get a GLP-1 from the GP. It is a fantastic medication, and it is pretty safe, to be fair, as long as you've never had pancreatitis or thyroid cancer in the family, and you're not actively binge eating, and your kidney function is normal. It's pretty safe. Again, no training for GPs, but GPs seem really keen to be able to prescribe this. It's my last slide. This is my sister. My sister has been on GLP-1. She's got lipedema. You can see she's type 2 lipedema. You see in the first photograph on the left that she can't put her legs together. Her mobility is appalling. She's standing there unassisted, but she's 2 crutches, and she's got really, really poor health. She's only 58. But you can see that she is struggling on the left. She's got classic sort of fat pad on her thighs. On the right, which is 6 stones lighter, she can actually put her legs together. She's walking without crutches. And although she still has her fat pad that you can see, it has significantly reduced her symptoms. And that's me finished.
Thank you, Nikki, for persevering and giving us that really useful overview. I think there's so much we could say, but I'm going to hold all those thoughts for Q&A. I'd like to hand over now to Dr. Gabriele Ferber, who is joining us from Hamburg in Germany. It's always wonderful to hear Gabriele talking about nutritional approaches to lipedema, because it's one of the most challenging things, I think, for people who live with lipedema, that you can't not eat. So what to eat and where nutrition fits in, and particularly how it intersects with GLP-1 medication. They're topics that Gabriele and I and others like Shari have discussed endlessly in the Lipedema World Alliance, and Gabriele holds the top 2 slots in our most watched videos on these topics. So I know that she'll have so much to say that will give us a really useful briefing. So I won't steal any more of your time, Gabriele, but I'll just ask you to take over, share your presentation with us, and give us your wise thoughts and experience.
Thank you so much, Kate, and thank you for inviting me and giving me the opportunity to talk. So I'm going to start. I have no conflicts of interest. Before we delve into the actual topic of nutritional approach for lipedema, I want to take you through a few statements which I think are important. And as you probably, or you don't know, but I have been treating patients this afternoon. So in between patients, I sometimes had a glance on the presentation. So some of the things that I say might have been mentioned before, but I think what I'm going to say for the first 2 or 3 slides is important for the rest of what I want to say. So you all know the definition of lipedema by now. It's a painful, disproportional, symmetrical disorder of adipose tissue in the limbs, in the extremities. This is one of the really first statements in our guideline. So only legs or only extremities are affected. And that is important because if we talk about weight or possibly weight reduction, we must take into account that lipedema morphology is different from obesity. And although obesity and lipedema co-occur, are very often coincident conditions, lipedema is not caused by obesity, nor is it triggered, as some colleagues sometimes say. You can't trigger lipedema unless you have the predisposition before you put on weight. Nor, on the other hand, does it cause obesity. So if it is present, of course, both conditions have to be treated, and obesity, very importantly, can cause secondary lymphedema. So the progression to lymphedema is, in most cases, is caused by increasing weight. To clarify that, this patient you see here has got a very slim waist, and because the weight of the extremities is so important, or is so influences the BMI, but would not be could not be considered as obesity or overweight. BMI is not a robust means of characterizing overweight and lipedema or obesity, because it can provide false high values in the region of at least overweight or mild obesity due to the increase in the adipose tissue in the limbs. This might also, in extreme cases, be the case even for obesity grade 2. So we recommend a more accurate assessment should be done by at least combining BMI with the waist height ratio, because that is independent of the total weight and of the weight of extremities. So of course you can't diagnose lipedema by using the waist height ratio, but if waist height ratio is normal and BMI is not, this is a strong indication that there is disproportion, and it is again it proves there's no central, no abdominal obesity. So we think this is really important to keep in mind, especially if considering bariatric surgery. So coming to our general recommendations for nutrition, as you can see in the headlines, nutritional interventions are one of the means to reduce pain. Of course, nutrition is important to keep a healthy weight or to reduce weight if overweight or obesity are present. But most importantly, nutrition and weight management shall be used to help patients maintain or regain mobility and functionality and prevent the disease from progressing, especially from progressing volume-wise. The aims shall therefore be, the strongest recommendation, achieving or maintaining a healthy body composition as well as a reduction of pain and other symptoms. Healthy body composition and reduction of symptoms. That's the overriding goals of nutritional interventions in lipedema. Of course, if overweight or obesity are present, the treatment for those conditions shall be included in the overall concept. So you'll see the weight, the focus, primarily the focus is not on weight. Don't look at the scales, but look at a healthy, or try to achieve a healthy body composition. I can tell you, I had to explain to my colleagues what a healthy body composition is. And it is characterized by a balance between fat mass and fat fat-free mass. Fat-free mass is more than muscle mass. Fat-free mass is also bones and fluids. But of course, the changes in the fat-free mass, when they happen during, for instance, either GLP-1 RA therapy or during nutritional interventions, the change is usually caused by the change of body cell mass or by fluid, and both have to be monitored. We use BIA. I'll show you right at the end. I'll show you a slide from that. Patients have to be educated or told that lifestyle and eating habits do influence lipedema, pain, and progress. They are not they are not completely helpless. They can do something for their symptoms. And very importantly, I could only hear part of the GLP-1 presentation, but I was very impressed because at the end, she said that there was more muscle mass, which is extraordinary because the main problem in GLP-1 RAs is the loss of muscle mass. And whether you use those medications or whether you use nutritional interventions, you have to watch out that your muscle mass does not decrease in order to facilitate a sustained weight loss. Not to reduce the energy expenditure or the basal metabolic rate. And a very common condition also in lipedema is sarcopenic obesity, meaning obesity you can't see looking at a patient. You can, once you examine them, when you palpate, once you touch them, but you can't see from their morphology whether they have a good muscle mass. There is sarcopenic, meaning not enough muscle mass can be present in obesity and has to be treated, recognized and treated. So we have to tell our patients that it is very important to have an active lifestyle and to avoid becoming obese. And in order for them to achieve that, they have to realize that any short-term diets are not useful, are absolutely damaging to their further development. And instead of short-term diets, they should adapt their eating habits permanently to a healthy, individually tailored nutrition. Healthy nutrition can be very different, varying between individuals, and it has to be individually tailored. If obesity is present, the additional volume can be reduced. It's not true that you can't reduce volume of the extremities by either sport or nutrition. You can, at least if there is additional overweight or obesity. What we of course recommend is lifestyle-wise exercise in compression and most beneficial aquatic exercise. And we know that again, in exercising, the main goal is not losing weight. It's very difficult to lose weight by exercising. You have to exercise a lot to lose weight. But it helps to reduce stress, which again helps with weight loss. It's got antidepressant effects and it's got anti-inflammatory effects. So at least where obesity is present, all those side effects are very helpful. The general recommendations in our guidelines are, as far as weight reduction is concerned, is of course always the same, whether there's lipedema or not, and if appropriate, and very often it is, behavioral therapeutical measures. And most importantly, it must include both the weight reduction phase and long-term stabilization, because that is the stumbling block. Losing weight, same applies to GLP-1 RAs. Losing weight is not the problem. Keeping your weight is the biggest stumble block. And patients shall also be informed that their eating habits have either favorable or unfavorable effects on their metabolism, especially on blood sugar and insulin levels, and therefore on lipogenesis and inflammatory processes. We know, and we have to tell our patients that high insulin levels, so of edema, and high insulin levels are always pro-inflammatory. So spikes of blood glucose and insulin shall be avoided at all costs. And in order to do that, for instance, sufficient intervals between meals should be observed. We have, in addition to those general recommendations, we have two recommendations for specific diets. Weak recommendations because the evidence was not really high enough to give a stronger recommendation. There has been, in the meantime, in those 1.5 or one year and 9 months since the publication, evidence is mounting. So if weight loss is intended, may be recommended on account of its anti-inflammatory properties. And here the focus is on fighting, diminishing the silent inflammation, and especially on creating awareness of pro-inflammatory triggers. The other diet that we may recommend is a ketogenic diet because of its weight reducing and anti-inflammatory as well as symptom reducing effects. And here, since the publication, I'll shortly go through the papers with you. There is much more evidence by now on gastrointestinal hormones and subjective ratings of appetite, on the changes in pro-inflammatory cytokines and fibrotic growth factors. And in a small subgroup using MRI, they looked at the effect of a low carbohydrate diet on the subcutaneous adipose tissue of the calf. That was a small sub-study. They used a low carbohydrate diet versus a low fat diet, 1,200 kilocalories, so energy reduced over 8 weeks. They studied the effects on pain, quality of life, weight and body composition, inflammatory markers, and satiation or hunger. And again, the low carbohydrate diet was superior concerning weight loss, pain intensity, reduction of calf circumference and subcutaneous tissue, satiation and hunger. And also they observed a reduction in inflammatory markers, which I have been doing for years and years. But the interesting fact was that although the inflammatory markers on average were reduced, there was no intra-individual correlation with pain reduction, meaning that if inflammatory markers were greatly reduced, it was not necessarily did not necessarily correlate with the pain reduction. And also, of course, there are lots of lipedema patients who don't show any increased inflammatory markers. And I think if they do, it's mostly to do with additional obesity. But this finding suggests that at least systemically, inflammation markers do not correlate with pain or with symptoms. So from a practical point of view, what as a patient or what as a healthcare professional can you recommend, or how can you start, how can you approach a nutritional approach like that in your daily life? First step, always reduce sugar, refined carbs, reduce or avoid processed foods containing additives, chemicals. Eat whole food, preferably prepared by yourself, so you are in control of what you eat. Most importantly, whether you use GLP-1 or not, or eat a diet, eat enough protein. And we start at 1.2 to 1.5 grams per kilogram reference weight, not actual weight, but a reference weight, which means a weight that we more or less want to achieve. If you already feel a slight improvement, which might well be the case, consider further reduction in carbs towards a very low carb or keto diet. But in my opinion, ketogenic diets should always be conducted under clinical or medical supervision, to not only to avoid side effects, but also to be safe. They are safe if a well-formulated ketogenic diet is safe, but I think you need supervision. You need a thorough and extensive laboratory workup before you start. It's important to watch out for electrolytes, because as you lose fluid, water, you'll also lose electrolytes, and you have to supplement them possibly. Medications have to be managed and very often reduced, like blood pressure medications, for instance. And very importantly, management of body composition, documentation of body composition, in order to keep your metabolic rate up to normal. So what is a ketogenic protein optimized diet? There are two requirements. The carb intake has to be reduced below an individual ketogenic threshold, which is around 50 grams per day in most people. And in order to prevent muscle loss, in order to preserve your lean body mass and your basic metabolic rate, you have to give or to consume, to take in enough protein. If you don't do that, in nutritional, in say ketosis caused by starvation or by prolonged fasting, you will inevitably lose muscle mass. And in order to prevent that, you have to possibly increase, very often women often have to increase their nutritional intake of proteins. If that happens, ketones are produced. They can be used by almost all organs, especially beneficial, or the brain is can use ketones especially well, which is why in various neurological and neurodegenerative diseases it shows positive effects. And a very, very simple slide here is how I would like to explain what we want the patients to eat. Carbs reduced up to 50 grams per day. Protein, as I said, 1.2 to 1.5. It might have to be higher, but rarely. And then there's always the term low carb, high fat. Now, how high your fat intake is depends on your goals. Fat intake is okay. Choose healthy fats. But the amount of fat that you take in depends on whether you want to lose weight or whether you only want to improve your symptoms. If you want to lose weight, you have to reduce your fat intake, or you have to use a slightly energy reduced diet. And it's also very important, talking about healthy fats, anti-inflammatory sources for protein and fat oil, plus possibly a supplementation of omega-3 fatty acids, which are anti-inflammatory, can be very helpful and should be recommended. Just one example, this patient lost 20 kilos in 3 months at the end of 2023. After that, she underwent liposuction in our surgery. So she had to prepare herself for liposuction. And I think this is absolutely mandatory, that any patient who wants to undergo surgery should know how to eat and have a good weight and general body composition before she undergoes the operation. And you can see this is BIA, bioimpedance measurement. You can see she is really, this is a bit, you have to see this is the first measurement, this is the second, this is the 15th. So she climbs up, her muscle mass is more or less preserved, her overhydration, her increased hydration is diminished. She is in the normal range here. then only here, number 16, which is here, that was immediately, or not immediately, but only a few days after the first operation. So there was more fluid, and you can see how her BII seems to have deteriorated, but we can explain that. So I think this is a very useful tool to use for either GLP-1 or nutritional intervention. So my take-home messages are there is no one-size-fits-all solution. It's got to be individualized. But an initial ketogenic diet as a reset phase can almost always be recommended in order to manage weight and, very importantly, to manage symptoms. For long-term sustainability, the individual tolerance of carbohydrates, what sort of carbohydrates can be tolerated in the long term, should always be investigated. And what we want is metabolic flexibility, so switching between very low and moderate carb consumption that allows for alternating phases between nutritional regimens and helps with long-term adherence. A well-formulated ketogenic diet can reduce weight and volume of extremities, can have or does have anti-inflammatory effects due to the reduction of AGEs, that advanced glycation end products, which are produced in the glycation of carbohydrates and are highly pro-inflammatory. Reduction of insulin secretion, more beta hydroxybutyrate as an anti-inflammatory agent, and it can decrease the pro-inflammatory cytokines, which is probably most important in coincident obesity. And also, it can also decrease the retention of fluid and sodium and help with symptoms and edema. But most importantly, it can decrease lipedema symptoms such as pain, feelings of heaviness, and congestion. And that is the end of my presentation.
Thank you, Gabriella. That was a super briefing, and you covered a lot of the questions that people had. We are running a little bit tight for time, but I would still like to take some questions. So I will ask Nikki if she can turn her camera back on, Dr. Nikki Maisie, and also Leslie Steinitz as one of our presenters. Gabriella, you've talked quite a bit about reduction in levels of inflammation, and there's been quite a few kind of people asking about that. Are there any agreed measurements for that, or is that more seeing a decrease in each individual patient from measurements before they made some of those changes?
That is what I tried to hint at or to comment in my presentation. The Norwegian group, as well as I in my long experience, if there is increased inflammation markers, we see they get reduced. Yeah. We have many lipedema patients, especially those who are not obese, who have perfectly normal CRP, for instance, values. And what we think is that we haven't found...
She's just dropped a
we haven't found an inflammation marker, inflammatory marker that will help us. And also, if you look at the many papers that have been published during the last years in different labs, they find contradictory results as to which is reduced and which is not.
Which is always challenging, isn't it? And that's why I'm so definitely starting on an unfair note by asking you to try and opine on it, Gabriella. One of the reasons I think it becomes a challenging question, if I may, is because Nikki talked about, as a GP, challenges on what kind of blood tests they can carry out in the UK. And I think certainly at the moment, there's not necessarily a suite of lab tests that are regularly performed on people with lipedema. And that's something that certainly in the Q&A, people have talked about the challenges if they're going to, for example, practice a ketogenic way of eating, in terms of how they can tie up with primary care on what kind of measurements may need to be undertaken, whether it's kidney function or other tests. Is there anything specific on that you'd like to say, Nikki? Or would you like me to offer you a different question, as I have?
Yeah, no, it's fine. So I think with my GP hat on, I think we don't standardly do testing on people doing any sort of diet. You know, we don't sort of we don't get involved in that direct way, really. We don't sort of check their bloods. Maybe we should with a tier 3 hat on. I know that our dietitians sort of they'll do a more moderate, they won't do a completely ketogenic diet, they'll do a reduced carbs diet, so we don't get into that sort of difficulty around whether we should be monitoring things or not.
Thank you. So sticking with the topic of monitoring and kidney function, if we may, when you spoke about GLP-1 receptor agonist medication, you spoke about suitability for people. We've had a number of people asking about things like whether if people have any kind of form of kidney disease, it's something they shouldn't undertake. And really, could you say a little bit more around kidney function and around optimal?
Yeah. So generally speaking, as long as your kidney function is reasonable, a slightly reduced kidney function isn't the end of the world, but normal kidney function, obviously, with any medication is ideal. The two really big no-nos are pancreatitis, which may have happened in people who've had gallstones. And you're not supposed to have GLP-1 pancreatitis. There is thought to be an increased risk. It's a small risk, but there is an increased risk. And the other one is a family history of thyroid cancer. In the original trials, I think a handful of people had thyroid medullary cancer.
Yes. And we did have a question saying, is that purely restricted to thyroid cancer or other forms of thyroid disease? Because, for example, a lot of women in the general population, I think in many countries, certainly many Western countries, will have hypothyroidism more commonly than hypothyroidism. Fine. But
absolutely fine. You can have an over or an underactive. That's absolutely fine. It's the thyroid cancer and this medullary type, and it's family history as well. It's not just if you've had it. If there's a family. Right.
That's super helpful. Thank you, Nikki. And I have another question for you, if I may, which is, and equally Gabriella or Leslie might want to jump in on this one because I think it's a good panel question. Why do people plateau on GLP-1 medication? And are there any factors around when that plateauing will occur for different people? And accepting there's no research on how lipedema people's experiences differ to other patients taking this medication, does anyone have any anecdata to share about how that plateauing might compare or the weight regain? And I think, Nikki, probably you're an ideal person to start with, but I'd like to give the other two afterwards the opportunity to chime in if they'd like to.
Yeah, so any weight loss, it rarely goes in a straight line. It goes down, it plateaus, it goes down, it plateaus. And there's a number of reasons for that. But often people will be matching their calorie intake at that particular point. But the other thing is, if you lose weight really quickly, then often metabolic changes happen and you do reach this sort of break point. We find that really commonly with any weight loss strategy, people doing really well. With the GLP-1s, I think the first injection, everyone seems to be really hit by it and feels really wiped out. The first month or two, it seems to be very active. The advice we give is a couple of days before starting is get used to half portions, because it can take up to 24 hours, 48 hours to really kick in. People then get caught with the whole kind of, I've eaten too much, I feel really awful with it. But I think with all things settle down a little bit. I think also, I personally wouldn't advocate going up the steps. In the actual trials, every month they went up another dose and they stayed at the top doses. And I think some people are absolutely fine on lower doses and still losing weight and feeling better. And but that might then bring that plateau a bit more like a hit plateau. If you hit plateau for too long, that's the point where I'd say you need to maybe go up if you do anything. But I think it's also the time to look at everything else. It's not just one fix. It is looking at everything else and reviewing everything else that you're doing. It doesn't take much of a calorie change to increase or decrease weight. We're talking about weight rather than lipedema here, but it's literally 100 calories a day would put half a stone on a year, or half a stone to a stone a year, depending on your height. So yeah, I think it's more look at everything, look at the dose that you're on. But actually, people that sit tight, I say to patients who aren't on GLP-1s who are losing weight and then finding they hit this plateau phase, I say sit tight for 6 weeks if you can. The worst thing you can do is to stop doing what you're doing, because at that point, that's when this regain, this yo-yo dieting, this significant regain will happen really quickly. So it's just try and keep, so it's not going to go back on, but it's the losing bit might take a little while to kick back in. And in some patients, it then starts going back down with no other interventions. Hard to do.
Thank you, Dr. Maisie. Did you want to come in at all at that point, Gabriella, or you?
Well, I'd just like to add, one has also got to take into account that with if there is muscle loss, your metabolic rate goes down, and you will not lose weight on the same amount of calories. So just to stress the fact that the add-on is the medication. Medication is the add-on, and lifestyle and nutrition changes are the basis of that. And if people don't, I mean, in my experience, I haven't got that much experience, but I have a few patients, and if they don't get really taught to eat enough protein, they won't eat enough because they are not hungry and they haven't got a good appetite. I always compare on a ketogenic diet, you are not hungry, but you keep your appetite. On GLP-1s, you might not be hungry, but you also lose your appetite and you don't really feel like eating healthy food, possibly. And that might be one reason. And the other reason is that even in the trials, I mean, Ozempic and Wegovy, we have never been as the results have always been, or the reduction is less than with Mounjaro, for instance. And I've just seen that they are trying now to increase the dose, the 2.4 doses, threefold. I can't imagine how that will be tolerated by patients to take 7.2 milligrams of Wegovy or whatever it's called, if in terms of side effects.
Thank you, Gabriella. And I know, Leslie, you specifically referenced challenges around plateauing when one stops, well, particularly about weight regain when you stop GLP-1 medication. Is there anything else you'd like to kind of say on that?
Just very quickly, I'd certainly echo the recommendation not to go up in the recommended rapid rate, because at the end point will, I think, probably be the same. And no one's referenced something called set point weight loss or set point weight, which is something that I've read about in the literature. I'm no expert, but the suggestion there was that you will not go beyond a certain bit below a certain weight, because your body resets to that new normal. And certainly that's how I felt. My weight went down in virtually a straight line until it stopped. And then it sort of bounced around a little bit. And my diet is much better than it was. My exercise has gone right up. Doesn't seem to affect it at all. So my body composition seems to have changed, but the weight has stayed the same. So there's just a bit of personal.
And we appreciate you sharing that, because I think that's always very much the challenge for people living with lipedema and people trying to support people living with lipedema, is that we are at the stage when it's very much an awful lot about people's anecdotal experiences as much as it's about the small amount of published literature, Leslie. And certainly, I think the whole topic around lipedema and weight and balancing obesity, we've had people asking questions like, how do you decide what percentage of somebody's fat is obesity versus lipedema? And as Dr. Gordon said earlier, there's so much we still don't know, and it makes it so hard. And certainly as the daughter of somebody who suffered with significant obesity as well as with lipedema, and had a very restricted life as a consequence of that, and who had the experiences you reference around coming off and experiencing a rebound weight gain after stopping medication, I think it's certainly something that we all appreciate, that there's a lot extra to do. But I would like to thank everybody in my panel. I think we've had a really, really powerful discussion. And I think it's been super impactful for us to be able to cover these areas, and hopefully people will come out of it with some other ideas, hopefully, Nikki, about what else can be done in general practice and around the connections between general practice and tier 3 weight management in the UK. and around all the wider nutritional challenges, Gabriella. So thank you. So I think, having checked the chat, I think we have addressed most of the questions asked at a kind of grouped up level. There are other questions people have around managing symptoms and managing pain, which I think are challenging. I think, Gabriella, probably your last comment on that would be, as you said, there's not necessarily a linear relationship between pain reduction and weight reduction. And I think that's something that's often important for people to understand, that equally we could have done a whole session on pain and lipedema, I think, and surfaced an awful lot of unanswered questions on that. So I think at that point, it is probably for me to take us into the comfort break at the end of this piece, and to thank everybody on my panel. And then we'll come back for session 3, which will be liposuction and lipedema, where we will hear from some of our other colleagues from Germany, taking us through their experiences around the LipLeg study, implications for the UK, and also some more patient voice experience around balancing conservative and surgical therapies with our colleague Shari Fetzer. So I think at that point I hand back to our colleagues at the RSM to manage our break. Thank you, everybody.
Welcome back, everybody, after our short break. I hope everybody who's a patient did take advantage of the break and have a bit of a move around, because that's one of the things we always recommend at Lipedema UK, that you don't stay static for too long, and really make sure we all get up and take exercise as often as possible. I'm really excited to be chairing this next session, because we are now going to be talking about the future. We're talking about the future potential for what could happen to treatments and the people who are going to help us get there. All our previous speakers are doing so much great work helping patients currently, but at the end of the day, most people want to consider surgery, and it has already been proven to be a huge disadvantage for many of our Lipedema UK team and for many of our patient members and people that we meet. Most of the surgery happens in Germany, and I'm especially proud to be introducing some really amazing German surgeons today. I'm hoping they're going to turn up, so that's my slight worry. So I'll just see if they're, I can't see if they're there yet. So I'll be filling the gap until they appear. But our first German colleagues, like Kate and I are members of the Lipedema World Alliance, and they run an absolutely amazing surgical center in Potsdam, Berlin, where patients of all stages are dealt with. And it has proved to be an amazing experience for all the patients we've met. And 2 years ago, Dr. Godson has his team hosted the very first Lipedema World Congress, where we all went to Potsdam and we met the surgeons. We saw lots about their surgery, and we had an amazing time collaborating with so many wonderful people across the globe who are really taking up the cause of lipedema patients and helping them. So we are so thrilled that they are going to be giving a presentation on their methods. I'm still waiting for them to join. So let me see. Sorry, just here we are. There they are. I'm so pleased to see you. I'd like to introduce Dr. Gods and Giz, who are both surgeons at Potsdam. I know they've been doing surgery today, and you have just the most wonderful facility. We're so jealous of what you offer patients, and we know you have a constant stream of UK patients coming to visit you and benefiting from your treatments, and also the wonderful attitude you have towards patients, because I know you both have such enormous empathy for the plight of lipedema patients and are so happy to be able to change their lives. So I'm going to hand over to you people, And thank you very much for joining us today.
Thank you very much. Thank you very much.
Thank you very much for having us. I'll start by sharing our screen so we can show the presentation as well. So I will start with the first part of the presentation, and then I will hand over to Dr. Goetz. So we will be talking about our surgical treatment of lipedema and basically the entire concept of our treatment, the stay, pre and post-operative care. We have no conflicts of interest disclosed, and of course this has been talked about also by Professor Gordon and Dr. Faber, that lipedema is a painful disproportionate symmetric fat distribution disorder of the extremities that spares the hands and feet. Lipedema was first pictured as early as 1500 BC, as seen here in ancient Egypt in the Hatshepsut temple, and it was first described, as Professor Gordon already said, in 1951 by Alan Hines. So we'll dive right into the surgical therapy. And the surgical therapy should be considered for patients with insufficient or no symptom relief through conservative measures. I'm just going to this one. There we go. What are the objectives of the surgical therapy? First of all, we want to achieve a subtotal fat tissue reduction in order to reduce the pain and improve the symptoms, as well as, of course, improve the mobility with decreasing circumferences and improve the quality of life. Our data has shown that with liposuction or the surgical therapy, we can reduce the need for conservative treatment. Of course, we reduce the limb volume, and with that, the mobility. And as a side effect, we try to improve the appearance of the limbs, of course. Why do we operate? At the end of the day, it is to halt further progression or consequences of leaving lipedema untreated. Patients, as already mentioned, commonly have concomitant obesity. As seen on the right here, it's a complex case with lipedema, obesity, and lymphedema, and requires a multimodal therapy approach, interdisciplinary, but we'll get to that. This patient is the patient you've just seen in the slide prior, and she had an incredibly difficult time. She's only 36 years old and has stage 3 lipedema and secondary lymphedema, most probably secondary to her obesity. How do we prepare the patients? It all starts with the patient selection. How our center has done it for the last, since always, more or less, is that our patients are required to come with an established diagnosis, and that diagnosis can then be confirmed by us. Ideally, patients receive 3 to 6 months of complex physical decongestant therapy prior to coming for surgery. Of course, in Germany, if you want to have the surgery covered by insurance, then 6 months of complex physical decongestant therapy is a must. As said, then the diagnosis can be confirmed by us, and the indication to surgery is then placed. What is important is that before performing surgery, any kind of comorbidities, especially also along the extremities, should be identified and treated prior, such as obesity and varicoses. Many people ask if we have a cutoff BMI. As not a very reliable measure in lipedema patients. So the waist to height ratio should always be considered as well. All of these patients have a BMI of over 32 to 35. However, obesity is not the main problem. As said, vascular diseases have to be identified prior to treatment and have to be treated accordingly before coming for liposuction. Patients are required to have a blood test analysis prior to surgery. We check for the hemoglobin values, we check for the iron stores, the vitamins, especially if they've had bariatric surgery prior, then we have to identify any kind of deficiencies of iron or vitamins B6, B12 and substitute those accordingly. Patients ask if they have to diet prior to surgery. We ask them to maintain their weight. There is no point in starving yourself for the surgery. If a lifestyle change goes hand in hand with losing weight that is sustainable to the patient, that is perfectly fine. But the goal should not be to lose weight for the surgery, because commonly patients will experience a rebound effect afterwards. Then in patients who do have an edematous component as well, we ask them to intensify or increase the frequency of manual lymphatic drainage and intensify the compression therapy 4 weeks prior to surgery. They should also intensify the movement exercises to increase their cardiovascular health. Some patients experience psychological comorbidities, severe depressive episodes. It is important to only operate in a stable mental state to be able to ensure the post-operative compliance. And patients will need compression garments after surgery as well. And these should usually fit for 6 weeks after surgery, and then they should be fitted new. Then coming to the surgical technique, I will hand over to Dr. Goltz, who will explain a little bit more.
Today I am going to talk a little about surgery technique. Normally we use a general anesthesia. We give a single shot antibiotic, and we have two options: palm assisted or water jet assisted for liposuction. We have 3 different cannulas with an averages of 5, 4, or 3 millimeter. We close the incision normally, and this is very important to regulate the patient body temperature. Normally, patient need a key operation. We begin with the front side and the legs. After 3 months, back of the legs, and 30 until 80% of patients need a liposuction for the arm. We are waiting 1 year. After 1 year, if you have a skin excess, we can do a lifting. The quality, we can remove a fat 8 until 10% from patient weight, and this is very important to the bleeding part, not more 20%. We have normally they are deep compartment epiphyseal. This is we use of cannula 5, superficial, subcutan. We need a 4, and subdermal we need a cannula 3. We started normally. We started with marking. This is very important from hip to ankles. All of the fat tissue removed after the operation. We remove all of the fat from hip to ankles, 360 degrees. Here you see that. We started with incision in typical area to remove all of the fat. Yes, we started with the infusion in all 3 compartments. This is power-assisted liposuction. Next is water jet-assisted liposuction. Here we do that in 3 compartments. In this time, superfacial, subdermal, 3 cannula.
We do this to promote skin retraction. And just for information, in this video, only a small portion of the thigh has been treated for demonstrative purposes.
Very good. Normally, after liposuction, we started with manual extraction. We try to remove the fat manual. We have 2 goals. One of them is more aesthetic, and another one is more fibrotic knuckles to remove. Here, a short video. Next, please. Here is for the aesthetic and modeling. Next, please. Look at here, this is very nice. Okay. After the operation, this is very important. How much fat we remove? Normally, we use a pinch test on, we say 2 centimeter. Lower 2 centimeter is very good. In all of the area. Next, please. Yes. Patient need to wear compression clothes after operation in operation room. We started with ML after the operation, and the first day compression closes for 6 weeks. Well, this is very important to mobilization as soon as possible. We say do everything, exercise, aqua, everything. Complication, we have very, the operation is very safe. If you have a complication, it's very little bleeding, infection, seroma. You can hear, normally we give antibiotic after that if you have this problem. This result is stage 1 for and after the stage 2. This is very important for the arm from shoulder to wrist, remove all of the fat. normally, if you have a stage 3, you have a lot of skin after operation. We waiting 1 year, and we can, if you have a skin excess, we can do a lifting here, a body lift. With future, but we do. But also, I can only speak about that. Next is, we do a lot of research. Post-stem, we take a fat from patient, lipedema patient, and bring that to a lab. We try to have to compare with an aesthetic patient. I hope we have perhaps 5-10 years of biomark. This is very important. As another, we have 3 research group. Here we check a fat from lipedema patient from abdomen and on legs. We try to know everything about fat. Yes. This is one of my research group. We see lipedema fat is different to control fat. We have more fibrotic fat. Is a difference. We have a lot of research about that. We have 10-year research what happened after 10 years if you do the liposuction. Yes, in our center we don't use lipedema fat for aesthetic, for post reconstruction. Why we don't have any research about that? We don't have evidence about that. I have 2 patients. Who did that in another center. At the moment, she had pain in breast, and we don't know why. I think we have to waiting. If you do that, we have to explain a lot of matters, a lot of news for the patient, and we can do that. Yes. What is my take-home message for you today? Lipedema is an illness, and patients have a lot of comorbidity. Liposuction is only a small part from this treatment. The patient needs to change lifestyle. She have to do more exercise. She have to change eating habit. She has to use all of the conservative treatment. And we know that we can help the patient, but the result is dependent on BMI, stage, age, and comorbidity. The earlier is the diagnosis, the better. We do this as Lipedema World Congress in Potsdam. We go next time in November to Rome. This is 5 until 8 in November in Rome, and after that we go to US today in Boston. We do speak about the first time about lipedema. The people was here for 3 years ago, but basic on he was very, very interesting for the center. Thank you very much for your attention.
Thank you so much. That's such an impressive presentation about your methods, and how wonderful to see that massive team you have there. I'm very jealous all the time, every time I think about it. We're going to now have a patient video from Emily, and then at the end we're having a panel discussion on the whole of session 3, if that's okay, if you can join us for that, if you have time. So I'd like to introduce Emily, who's a patient I've known for a long time. I've followed her complete journey through liposuction and seen the dramatic results. So I'd like to welcome you all to listen to her video.
Hi there, my name's Emily, and I'm here today as a patient story. looking at the liposuction journey that I decided to take. Best thing I ever did. But before I get to that bit, I just thought I'd share a bit about sort of my growing up and how I got to the surgery stage. So looking back now, I think I was showing signs as an 8-year-old. So back in about 1997, you know, if we look at photos now, you can certainly see a start of lipedema then. I had the sort of tree trunk leg shape already as a sort of 8-9-year-old, which, you know, progressed over time, and I did gain a fair bit of weight in my teens. I went to an all-girls school, secondary school, which sort of highlighted the issue and mentally became, you know, a bigger issue. I would just compare myself to my peers, and, you know, I knew I was different, or I could see I was different, and I would go on, you know, lots of fad diets, or I just remember, sort of, you know, I was fixated on my weight. I was fixated on my ankles more than anything. It wasn't even really my whole legs. It was just my ankles, or the fact that I didn't have any, as I used to say. And I'd compare myself to, you know, my friends or my peers, and I just knew that it wasn't the same. So I did eventually start kind of going to the doctor, and I'd ask the doctor for some help, and I'd been on these diets, and I'd lost lots of weight, and, you know, my waist would get very thin, but my legs wouldn't change. And the doctors sort of, they just sort of said, you know, you need to lose more weight, or you need to change what you're eating, or eat less. So if that means eat half a piece of toast for breakfast, well, so be it, which, you know, that's ridiculous. And in hindsight, that's just not okay advice for a doctor to give, but there we go, that's what I was given. So that was sort of my adolescent years, and, you know, it was difficult. It was, and actually, I sort of look back now at photos then, and okay, my legs weren't horrific, but obviously at that age, everything is worse, isn't it? So that was quite a difficult sort of period, and especially not knowing what it was. You know, you blamed yourself, or maybe it is my fault, maybe I do need to eat less or exercise more. But, you know, I've always been into horse riding and walking. I've had a dog for the last 20 years. So, you know, exercise has always been high on my list. I've always worked with horses, so I had quite a manual, active job. So it's not like a doctor could say, well, you don't exercise enough, or, you know, none of those things, but you still blame yourself, and it just became quite a big thing to me. So in 2015, at 26 years old, I was diagnosed eventually with Ehlers-Danlos syndrome, along with sort of POTS syndrome and a few other things, and lipedema kind of came, not with the diagnosis, but certainly as part of it. I was seeing a lot of doctors, and I just specifically remember seeing a locum doctor on an off chance, and I got to the point, every doctor I saw, I was showing her my legs and asking, like, any ideas? Like, I don't think this is normal. And she had actually seen it on This Morning on television that day. So that was amazing. And for me, you know, she said, look, I know what it is, or at least I think I know what it is. Gave me the name of lipedema. She said, I don't know how to help, or I don't really know where to go from here, but at least we've got a name, something to work with. So actually for me, that was a massive day, huge relief, more for anything, just for my mind. You know, it's not my fault, and you can kind of move forward. Once you know kind of what you've got, what you're dealing with, then you can progress forward. So in 2017, I think it was, I went to the Lipedema UK conference in Sheffield, and, you know, learned a lot more. You know, it's quite an overwhelming weekend, but an educational one. And I think from there stemmed the idea of surgery. You know, I was 28, and I was thinking, okay, already, like, I was having a lot of leg pain. So for me, the pain was the biggest thing. Yes, aesthetically and by looks, and, you know, it wasn't great, and I wasn't happy in that way, but also, you know, I make cakes for a living, as well as the riding, as well as the walking. Kind of my life in general was being affected daily. You know, standing up would hurt. If I was standing making a cake, it would be throbbing and hurting. Riding my horse, I didn't know it wasn't normal for your legs not to hurt. So every time I had my legs touching, you know, it was painful. I just thought that was normal, to be honest. I didn't, you know, why would you know that that wasn't? So surgery kind of came into my mind, and I fixated on the fact that on my 30th birthday, or by then, or certainly around then, that was my present to myself. And Who knows how I was going to fund it? That was a big problem. But I was like, no, I'm doing this. And that's kind of where I started looking. So, you know, it's a huge decision to make and it's a difficult one to choose. I also didn't like the idea of it being under a local anaesthetic. So for me, it was a general. So there was kind of like, there were a few things to start narrowing down the search. And I can't quite remember, but I think I had 4 surgeons I had sort of whittled it down to, and I emailed all 4 of them. And one still to this day hasn't replied. I ran a half marathon in the March of 2019. That was to raise money for my surgeries and also to kind of prove to myself as an absolute last ditch, like, I cannot change this. This is not my fault. There's nothing I can do, going through with the surgery. So off I went, 4 surgeries over a year. And I'll add the photos here kind of as I keep talking, just to sort of show the you know, the stages, if you like. So I had my lowers done, the fronts of my thighs with my stomach done, the backs of my thighs with my back done, and then the final one was my arms in February 2020. And in total, it was just under 27 litres that I had removed. Brutal, really brutal surgery. I really underestimated it. The first one was quite a shock. I flew home 2 to 3 days after each surgery, and, you know, once you got moving, it was better. Like, for me, my biggest issue was my blood pressure dropping and a bit of anemia after the 3rd one. So just had to like up my iron, drink plenty, like loads. But yeah, just rest and recoup. I mean, each one I was back to work within 2 weeks of each surgery, and that's back to working with horses. So pretty, you know, full on work, and I was okay. So it's difficult and it's a long journey, but it was so worth it. And I think if anyone's planning on doing it, you know, I would say go for it with everything you've got. We're now 5 years post, well, 5.5 years really, after my last surgery, and the results are still standing, still looking great. I'm still really happy. The pain has completely gone, never returned. And yeah, I mean, honestly, I wouldn't think I'd do it again in a heartbeat. It was difficult, you know, it was a lot, and it was a lot to fit into a year. You know, 1 surgery every sort of 3 months is what I was doing, but it was, yeah, it was really worth it. I won't be a bikini model anytime soon, but you know what? My legs don't hurt, and I'm super, super happy with how it all turned out. And actually, after 18 years of, you know, mental torment, it's gone. It's not my fault. And actually, okay, there's been a bit of regrowth in certain areas, but not enough to warrant a big problem. There's no pain returned. And honestly, very, very happy and super glad I did it.
Thank you very much, Emily. I say hopefully Emily will join our Q&A session at the end. And her story is such a great, exciting thing to witness and for me to follow over the years. Now we come to our ultimate presentation, and I would like to introduce Professor Manuel Cornelli, also from Germany. Professor Cornelli was one of the very original pioneering surgeons for liposuction for lipedema. He has a long history of association with lipedema and has devoted a lot of his professional attention to it. And I am so grateful that even in retirement, he has not deserted us. And he is working very actively with the German government, which he will explain, and also how that can ultimately impact what happens here in the UK because of the next NICE review into liposuction, which we know will take place following the German government's publication of their results. So over to you, Professor Cornelli. Thank you so much for participating today. And thank you for all the work you and Dr. Godz and the teams in Germany are doing to really, really improve the lives of lipedema patients.
So yeah, thank you very much for giving me the possibility, the opportunity to speak in here to this interesting thing of the study, which is called LipLux study. and I would like to show you what we did. Even if I do not know if we have any influence on the NHS with this study. The study was done in Germany. It's named a randomized controlled multi-center investigator-blinded clinical trial comparing efficacy and safety in surgery versus complex physical digestive therapy for lipedema. Long name, but a small name. It's a lip-leg study. So this clinical trial was published and founded by an organization which is called the Gemeinsame Bundesausschuss, the Federal Joint Committee, which is the highest decision-making body of the joint self-government of physicians, dentists, hospitals, and health insurance funds in Germany. And I will go quick to all these questions here. As you know, I do not need to tell this again. Standard conservative treatment is the conservative treatment of lipedema, and the lip-leg study wants to evaluate the efficacy and safety of liposuction compared to this standard CDT. We have a primary outcome, which is to reduce the pain on the legs in 2 points on the visual analog scale. And we have some secondary outcomes. I won't go deeper in this now. So at a glance, it's conservative versus surgical treatment in lipedema, and the endpoint is bring an improvement of 2 points of pain on the vascular analog scale. And we think, last sentence, these findings of this trial will have the potential to change the standard of care in lipedema. So it was a quite complicated trial flow chart of this randomized study with a pre-screening and a screening. We will not go deeper in this here, but at the end, just see the highlighted line. We had 450 study patients in a total of around about 800,000 items of quality of life and pain, which we had to ask them. So the doctors of the 11 centers did really to hard work to bring out all these data together. It was a long way coming to this study, beginning in 2014, and in 2018 it was the first time it was initiated, the procedure by the GBA, as I told before, but it took to January 21 that we had the first patient accreditation in the lip-leg study, and the results are still not published. The official results are still not published, and we expect them to be published in 2027. So you see, long way to walk to find a decision if the surgical or the conservative treatment is good, or which one is the better one. But in midst of all these procedures, in the June of this year, the Federal Joint Committee issued a positive benefit of the assessment to the surgical treatment of lipedema. It was surprising, but in recognition of the preliminary evaluation of the lipedema study has been investigated since 2019 whether the treatment of lipedema has an advantage over conservative treatment. Surgical treatment of arms and legs can be provided at the expense of the health insurance funds for lipedema patients in all stages 1 to 3. This is an unlimited decision, as the current evidence of the lip-leg study is sufficient for this. The decision applies equally for outpatients and inpatient care. The effectiveness of surgical therapy has been published national and international in many different ways over the last 24 years. Before the yet unpublished lipedema study, and there is actually little doubt about this. Dr. Goltz and his team showed you the really marvelous results. But with this new thing from the GBA, we have new rules to listen for. I would like to introduce you a few of these new rules, which are before we do the surgery. First of all, there was the aim. Liposuction should help alleviate pain in lipedema and eliminate any movement restrictions, thereby enabling an increase in physical activity. You see, the word is pain written in here. That's the most important thing which the liposuction is to aim on. And the lipedema is diagnosed, that's the next new rule, is diagnosed by a specialist in internal medicine and angiology, or a doctor for physical and rehabilitative medicine, or a dermatologist and venerologist, or by a specialist which is additional trained in phlebology. the specialists in plastic, reconstructive, and aesthetic surgeries are excluded as the initial diagnostic and later surgeons. We go on this later on. Lipedema is a disproportionate increase of fatty tissue that only affects the extremities. Just read this. We are talking only on the extremities. We are not talking any other region of the body, which you can hear sometimes that there could be lipedema as well. The committee and the specialists in Germany exclude these other areas. And due to the coincident obesity, which is quite often seen, as Gabriele Ferber on the other ladies told today, lipedema with BMI values between 32 and 35 kilogram per square meter is only permissible if the excess weight is largely caused by the fat deposits on the legs and arms caused by lipedema. So this is very new. Normally, it was just the BMI, and it was measurement. I don't know about BMI 40 was out of the surgery room, or kilograms 120. But here we have a window to treat the patients in this area of BMI if the waist to height ratio can clearly give us a sign that the fat deposits on legs and arms is caused by lipedema. This can be assumed if the waist height ratio does not exceed the following age appropriate limits. You know all these: 40 and younger, 0.5, 41 to 49, increase of 0.01 for each additional year of life, and 40 years and older, it has to be 0.6. If you are out of these lines, of these borders, you will not have a surgery in Germany. Lipedema and the coincident obesity must be considered and treated separately. This is new. This was never written in an official paper up to now, and the waist to height ratio is considered to be a measurement of lipedema. The BMI, which is constructively invisible in relation to lipedema, as you all know, applies exclusively for the assessment of coincident obesity. So obesity has to be treated adequately. If the BMI is more than 35, liposuction is not permitted, but it means that if the aforementioned limit value of the BMI or the waist to height ratio is exceeded, the obesity is first treated until the limit values are no longer exceeded over the period of 6 months before the indication of liposuction. So the weight constancy of 6 months has become a new condition sine qua non on the surgical treatment of lipedema in Germany. There's as well a good new rule between the lines written to recurrence and pseudo-recurrence. It's an old discussion if lipedema can come again after surgery, and my position since 30 years is no, it can't, it is completely removed. So now the paper is written in a region that has already been conclusively treated with liposuction. No new liposuction procedure may be performed. The important word is a complete surgical finalized treatment is required. Here we are approaching the healing understanding of surgical action, which can also be measured by the definite absence of symptoms after surgery. Means if there are still symptoms, the surgery is not complete. At Lido, it is a measurement, is a measure on all the things. And sorry, Lido means lipedema. It's lipohyperplasia dolorosa. New old rules is that we have to wear 6 months of conservative preparation before any improvement in pain, and the specific exclusion of the influence of mental illness on the symptom of pain was rejected because the recording of psychological stress is part of the routine anamnesis and diagnosis. Just again, the 4 I's principle. The initial diagnosis and surgeon must be 2 different doctors. These regulations as a milestone in the establishment of the surgical treatment of Lido, which means lipedema, in Germany, as it was common practice until now that the diagnostic physician could also be the surgeon, and in the vast majority of cases it was. This path is not now closed. Another interesting thing is that the Federal Joint Committee not only denies that a self-diagnosis without a medical physical examination is inappropriate in this clinical picture. Maybe it is in addition with perhaps checklisted recording of the anamnesis, at least requires, but it requires at least an examination of palpation and inspection to rule out all the other possible diseases. On the other hand, the committee insists that the specialist examination with diagnosis and 6 months of conservative treatment has to be. Then, even in the case of coincident obesity in the diagnostic window, stable weight ratios, and which means BMI, and a clear waist-to-height ratio, as well as the absence of a positive influence on the pain through CDT, make it possible to perform operations at the expense of the Central Health Insurance. Surgical treatment in Lido has been taken out of the incalculable private sector care and has arrived in the catalog of services of the health insurance companies in Germany, and that is a very good step forward for all patients. Just let me highlight this as well. This rapid development of the surgical procedures at Lido in the tumescence anesthesia has been observed worldwide since the 2000s. Popularity and public discussion via the internet increased at a similar rapid pace. Hardly any other lymphological disease has received as much attention and excitement in the last 25 years as the clinical picture of lipedema, which has been known since the 1940s. Consequently, traceability and empathy are the most important factors that prompt patients to conduct their own research. I understand this. However, this sometimes leads to discussion about lipedema deviating far from the stage of medical research and tending to define the disease and its treatment at their own terms. So knowledge gained from information on the internet does not replace a thorough examination of the facts and their interpretation. Despite of these concerns, however, it should be noted that those affected, or you, the patients, have used their influence to support and promote the establishment of lipedema surgery in many ways since it began in Germany in Düsseldorf 1997. This democratization of science by internet users is a new and unusual phenomenon in academic medicine. It must be observed. So let me just point out the last pictures, what we still need to explore. I'm sure we have to go on with questions how the measurability of the obligatory symptom on pain. We have to improve the clinical diagnosis through instrumental support. We have to have more knowledge of cell physiology and specificity. I think the adipocytes of lipedema are not the same than the adipocytes of obesity, and we have to discuss this. This is as well clinically obvious when you take a diet and you can't reduce lipedema volume by diet and sport, as you know. Differentiation from the adipocytes from obesity, I just told it, and medication influence to the disease. We talked today of the GLP-1 agonists. There is no science done up to now. Investigation on the efficacy of the conventional treatment, and maybe something like a prophylaxis, I don't know, but we need more data for this. So worldwide, there's a lack of meaningful cohort studies on the effectiveness of lipedema therapies. We have not, these studies do not exist. So we have a solution with the lipedema for PST. I would like to give you the possibility to be part of the group. If you like, you go to this international, to this electronic questionnaire. You can find it under this address. And thank you for your for listening. Thank you very much.
Thank you very much, Professor Corneli. It's so interesting how all these new rules are emerging from the studies you're doing in Germany. And obviously we are watching keenly to see how they impact on what's happening here in the UK. And we value your help and support in this. What I'd like to do now is obviously have our panel discussion, hopefully Dr. Godds and Giz will be able to join us. Yes, there they are.
Oh, yeah.
Emily's there, which is absolutely lovely. First of all, picking up on some of the outstanding questions that have been put into our Q&A forum, can any of you throw any light on the connection between hypermobility and lipedema? There's a lot of talk about gait and the impact on gait. Are these all three linked? What do you see in your own patients?
Yes. So what we commonly observe is that many patients who come to us for a consultation have a diagnosis of Ehlers-Danlos syndrome or hypermobile Ehlers-Danlos syndrome. As far as I know, there is only one study establishing some kind of a link between lipedema and Ehlers-Danlos syndrome, but it is something that we commonly observe. I don't know if Professor Connelly has experience with it.
I just can agree. It was taught by John Hepstead from first to have an idea that it's something with Ehlers-Danlos, but Ehlers-Danlos is extremely seldom. And when I have a look to my patients, I really cannot underline that this is around about 70%, which is published at the moment. Maybe 2 or 3%. I do not think it's more than the normal population. So I do not see this. Lipedema is stuff for itself. I do not see a connect to Ehlers-Danlos.
Okay, thank you. Emily,
Emily,
you mentioned you had it.
have you a problem with your Ehlers-Danlos situation?
Yeah, so I've got the hypermobility type of EDS.
Yeah.
Whether I wouldn't say it's because of that, but I think in quite a few cases it seems to be that people have both, but whether that's actually to do with each other, I'm not really sure. But yeah, I certainly do, and it's after the liposuction, it's just meant that my vessels haven't tightened up quite as much as perhaps somebody else might in my lower leg. So I still get a bit of tingling or swelling because it just maybe hasn't tightened as much as somebody else might post-operative.
Okay, thank you very much. It's an interesting discussion, which I'm sure will rage
Sherry
particularly
could ask the same question to the hypothyroidea. We have lots of patients with hypothyroidea, but it has nothing to do with the lipedema. And we treat this thyroidea with medicaments. It won't change anything in the lipedema. So it's the same thinking around.
So it's a coincidence.
It's a comorbidity.
Comorbidity, yes. Okay, thank you very much. And we've also got a question about the ulcer risk in lipedema patients. Have you had any particular
also in terms of leg ulcers or?
That's a good question because it doesn't say leg ulcers or not. Christiana Gordon did mention that there's not so much risk of some leg conditions, but this one is specifically saying if you think there is a connection between ulcers in any way.
I didn't see in 30 years an ulcer with lipedema in connection. It's the same question if you have any more ulcers with lymphedema. There's typically not, and you will always see them after vascular phlebological diseases. But due to lipedema, I wouldn't say they have a higher possible indication for ulcers now.
Okay, all right, thank you very much. I really like this issue of four eyes, two different doctors diagnosing patients.
Yeah.
Do you have any perceived way that will work out when this is an established procedure in Germany? What type of consultant will be in that pre-selection process?
So I'd like to answer. It's mostly misunderstood. It doesn't mean that two doctors have to see the same patient, the same situation at the same day. It means that one doctor has to do the first diagnostic, then they have to have a 6-month period with conservative treatment, and then this first doctor can say, okay, now you are finished with anything, all in data are good, I will send you to a surgeon. And then we send him to a surgeon, whoever wants to do the surgery. In former times, it was the surgeon who did the first diagnosis and the surgery. And this is stopped now. It has to be two doctors. One does the diagnosis, and he's not allowed to do the surgery himself. He has to send it to another one. This is the 4 R's.
Would that be the same for any international patients coming to Germany?
No, if an international patient comes to Germany, he's always a private patient, and then all these rules are unnecessary. If you come from the UK for surgery to Germany and you find a doctor and says, okay, it's a lipedema, he can do the surgery, he can start directly. He doesn't need to do 6 months before. He does not to have a second doctor, he just has to do a good diagnosis. These rules I'm talking about is only for German patients.
Okay, and that's connected to the health insurance aspect.
It is indeed.
I think you've previously explained to me, Professor Corneli, when you talk about health insurance companies, it's it's a different definition to what we have in the UK.
Yes.
Because when we say health insurance, we think private health insurance. Whereas when you talk about health insurance, it's the government-sponsored health insurance. Yeah, okay. We just have to keep reminding ourselves of that. One of our
that's a good idea. If you're privately insured in Germany, all these rules are not for you. It's only for those which are on the health insurance companies by the government.
So again, it's whether we are able to follow that model with our NHS funding, which obviously is something we'd all hope for in the future, that we can get it through on NHS funding, right? Dr. Godz, there's a question specifically for you, which is, how do physicians refer patients to you?
Normally, we have a lot of all the come to us, most of them is about a Zoom meeting, you know. Every Monday we do 20 patients from different countries. He send it to me an email, or we give you email address, we can do a Zoom meeting together.
Right, so you do it, the physician, you expect the physician to contact you or the patient to do it, having had to recommend both? You would talk to both, yes. Could you just tell us a bit more? Did you say 20 different countries? How do you particularly coordinate your international patients, and what particular requirements would you expect them to obtain before they approach you?
And what's important for our international patients is to have an external diagnosis and to present to a virtual consultation, please. So, because every case has to be evaluated on a case-to-case basis. Once patients book a virtual consultation, they receive a medical questionnaire and a lipedema questionnaire to fill out, which is then looked at by us, as well as photos of the clinical findings. And then during the consultation, we'll discuss basically how we would plan the therapy. And the only thing that they need prior is a compression garment and a blood test before flying to Germany.
Okay, thank you. Yeah, it's just good to clarify that. What we've talked about in previous presentations, and obviously one of my passions, is diagnosing people early and seeing people early. What is your youngest criteria, and how would you advise young patients like the young Emily, or how can you prevent patients such as Emily having, I think you said 18 years, didn't you, of torture, Emily, just trying to decide what course of action to take and when they should approach you, because obviously this is a big decision. Is there a better time from your perspective that you see patients?
The data, we've published a paper over a 10-year period, or a 10-year retrospective study, and the data clearly indicates that the earlier the treatment is pursued, surgical treatment is pursued, the better the long-term outcomes are, and the more sustainable they are as well. So it is a big step to take to pursue the surgical therapy, but I think for many patients it is an inevitable choice at some point. And if you have the choice or the option to do it earlier rather than later, then that is probably the more advisable path to take.
Yes, I think that's very helpful advice. And particularly, how would you advise parents? Because we get a lot of concerned parents as to they may suspect a patient has it before their daughter does. You know, they might see a family trait, or we certainly know a lot of mothers, grandmothers are anxiously watching their children as they grow up. How would you help them through that process of?
Normally we say if you are 15, we know that lipedema started with 15, 14 years, and we say, please use the first 3-4 years conservative treatment. We are waiting 4 or 5 years if you are very young, But we know that if you don't have any goal, any accept from conservative treatment, we have to do the liposuction. We know from the study, if you do earlier, it's better than if you are waiting, You have very good result if you have a stage 1. This is very good time.
That's what we all hope for, isn't it? That's what we all aim for. Do you have any comments, Emily, on what you're hearing this coming out of Germany, and what sort of hope you think that gives the patient population?
Yeah, I think it's great. And I think, the more we learn and the more long-term results we can see, hopefully that's the kind of data we can take back and use. Certainly, I think if I'd known, I think I slowed the progression down naturally by working with horses because I was in elastic clothing, leggings all the time, whether that had an effect. So I guess younger people, if you're worried, rather than making it like a big issue for your daughter, let's say, maybe naturally try and encourage leggings or compression sport leggings or something. Maybe there's ways of going around it for that conservative treatment without making it like a big thing kind of thing, because that was, it can take over. It did take over for me.
Yeah, very, very easily. Professor Corneli, yeah.
Yes, I would like to comment on this as well. Emily is the best example. And she had a surgery. Afterwards, she had no more pain up to now, I understood.
Yeah.
And I think you do not need any more compression stockings or something like this. Nothing. So
I do some in summer. I wear it, or
sometimes,
if I'm
okay.
standing for a long. But no, generally speaking, no, I'm done. Yeah.
Yeah. Okay. So you're done. So, Sherry, the first answer to your question is make a first and very good diagnostic. You need to know it. Even the lady, the girl is 13 years old. Doesn't matter. You need to know it's a lipedema, yes or no. If it is a lipedema, then you have to do a therapy. And this therapy has to be conservatively or surgical. There's no third way to walk. And I agree with the colleagues in Potsdam to do surgery as early as possible if necessary, and if they want to have a surgery. It is not necessary to do surgery. You can take conservative treatment up to, I don't know, 90 years old. Doesn't matter, long time walking. But due to the quality of life, Emily is the best example. It's completely changing after a good, well-done surgery, when anything is removed and there is no more pain. This we always have to imagine. These ladies, even the young ones, have pain. It's not just a question of silhouette. It's painful, and we have to reduce this painful disease.
Thank you. Yes, I think that's absolutely essential to accept that. And now we do have a light at the end of the tunnel, which is absolutely marvelous. I'm going to thank you on our panel, and I'm going to thank everybody else who's participated. I think one of the nicest comments we've had is that these sessions have filled one of our patients who's participated with so much hope and a sense of community. And I think that is what is an overriding feeling that I benefit from. And it's just amazing that around the world we're all finding each other, the people who really care and the patients who really need, the physicians who really care. So on behalf of all the patients, I would like to thank everybody who's participated today and everybody who's really going to change the lipedema patient journey in the future. It's been a wonderful experience. Thank you to the RSM for putting this event on, and let's hope we can do another one in the near future. Thank you very much, everybody.